Good morning, everyone, and welcome to the first AHEAD Symposium, Achieving Health Equity Through Access for All with Disabilities. My name is Robert Glickman, and I serve as the Associate Dean for Clinical Affairs and Hospital Relations and Professor and Chair of the Department of Oral and Maxillofacial Surgery at NYU College of Dentistry. I am also co-chair of the Advisory Board for the NYU Dentistry Oral Health Center for People with Disabilities. It is a privilege for NYU Dentistry to host this event. Before we get started, I'd like to note that we had originally planned to hold this symposium as an in-person event, something that we cannot do during the current public health situation. And while we don't anticipate any technical problems with the Zoom webinar format, I ask you to please be patient if they should occur. You'll notice that only the speakers, moderators, and panelists will be visible. While we'd like to see the entire audience, it's not possible with this format. Let me also add that today's event is being recorded and that closed captioning is enabled and can be controlled by your own Zoom setup. It is now my extreme honor to introduce Dr. Charles N. Bertolami, the Herman Robert Fox Dean of the NYU College of Dentistry. Thank you.
Thanks so much, Robert. This is the first of what we hope will be an annual event here at NYU devoted to addressing issues surrounding access to care in general, and particularly access to oral health care for people with disabilities. I want to begin by noting that we have almost 400 registrants in this meeting so far, and they come from all across the country and all across the world. And while we would love, as Robert indicated, to be doing this in person, there are some advantages to a virtual forum because the reach to people who could not have come to New York is so much greater. So it's my personal hope that as we move into future years that we'll do both an in-person meeting and also make it accessible through Zoom. We have a really remarkable group of people that are joining us today. These are folks from universities across the globe, national and international professional organizations, disability advocacy groups who were absolutely central to the creation of our Oral Health Center for People with Disabilities. We're joined by families, by healthcare providers, by service organizations, by the dental corporate sector, as well as people from state and federal governmental agencies. So it's a very diverse group and precisely the group of people that have the potential of making change. Now, I think it would be fair to say that all of us here really have an interest in access to care in dentistry, but not only access, also that it should be affordable care and not just care, but high quality care, care which is dignified and which is coordinated well throughout the entire healthcare system. In the case of the NYU College of Dentistry, we have had what was known as a special patient care program since 1971, a long time. And it was a successful program. We had a small number of really exceptional students who would engage in an honors experience in terms of so-called special patient care. And then an event happened to me personally about 5 years ago. And it led to a decision within the dental school and with the strong support of the university to vastly expand the care we offer to people who have disabilities and the special needs that is required as part of the education for future dentists. The event was very simple. After work one day, I was waiting for a bus on 25th Street here in New York, just directly across from the dental school. And I was waiting for the bus. A young man emerged from the dental building in a wheelchair. I think he was about 17 years old. That's what it looked like to me. And he had difficulty keeping his head upright. And he was going to the corner of First Avenue and 25th Street to wait for an Access-a-Ride van. And it struck me that with the various challenges that he may have had in his life, dental care should not be one of them. Dental care should be readily available and easily available for everybody, including people that have particular needs and particular disabilities. So for me, it was kind of an epiphany when I found myself thinking, you know, somebody ought to do something about that. And I'm looking at the building and I realize I'm the dean of that dental school. And so it didn't take long before we initiated discussions within the college. And we really had a remarkable team of experts here in the school. I never heard a complaint. I never heard an issue brought up by either a patient with disabilities or from our excellent faculty who were treating patients with disabilities. And yet I still knew that the facilities were not the best that we could offer. And so it was kind of an act of omission on my part to not recognize that, to not see it. And I think that's a problem that we often have in the dental profession, not noticing certain things that need to be noticed, particularly when we can make a difference. And so the discussions began within the college. There was great enthusiasm with the expertise that we had, but then even more significantly, the enthusiasm that was generated from outside the college by people who were willing to help us. These were individuals from the various disability groups, the advocacy groups from other universities. I think in particular of Stony Brook and Buffalo and Loma Linda. These were people, and Tufts, places where they were having experiences with successfully treating people with disabilities, and they were open to what we had in mind, was to kind of match what was being done and to try to raise the ante to increase the quality of the care and accessibility for people with disabilities. And of course, as a dental school, as a very large dental school, there was this unique educational opportunity for our students. The students have been absolutely fantastic. Rather than having a small group of students in an honors program, this expanded to having a rotation for every dental student, with the intent of having them acquire the competence, the confidence, and the compassion to notice things that I hadn't noticed in my years as a dentist. But there is still much more to be done. So today at NYU Dentistry, we're very happy to bring this group together so that we can learn from each other. I think that's the key. The people that are participating, whether on a panel or in the audience, have as much to offer, and that we can all learn from each other with the goal of advancing a more equitable healthcare sector for people with disabilities. So that's the basic idea here. Now, none of this could have happened in the dental school if we didn't have the strong and enthusiastic and consistent support of New York University. And the person who embodied that for us was the president, Andrew Hamilton. I don't think there's ever been a president of a university that has made more visits to its dental school than President Hamilton has been. So please join me now in welcoming President Andrew Hamilton.
Thank you, Dean Bertolami, and good morning to all of today's participants. Now, normally this would be a moment where I welcome you all to NYU's wonderful campus in the heart of Manhattan. But of course, we are living through a very different kind of world right now. But I am no less delighted to welcome such a large and distinguished group to convene virtually on such an important topic. Now, when Dean Bertolami first told me about the plans for NYU's Oral Health Center for people with disabilities, I was very excited about the potential, excited about the impact. But when I toured it after it opened a year and a half ago, and especially when I met some of the families who had benefited from it, I knew that I was witnessing something truly extraordinary. Here was a state-of-the-art center filling an urgent need and enabling a vulnerable population to receive top-level care with respect and with dignity. The only problem is that NYU's center should not be extraordinary. It should be ordinary. People with disabilities everywhere should be able to receive the same caliber of care, no matter where they live and no matter what their personal resources are. And that's why today's symposium is so important, particularly against the backdrop of the COVID pandemic, which has complicated care for people with disabilities even further. NYU's efforts to advance access to healthcare for individuals with disabilities would be impossible without partnerships, many partnerships with the public sector, the private sector, and nonprofit and advocacy organizations. And so we are thrilled that so many speakers and panelists will be sharing their expertise and insight today, including Timothy Shriver, Chair of the Special Olympics, and Neil Romano, Chair of the National Council on Disabilities. We are proud as well to welcome guests from the public sector. From the West Coast, we have David Chu from the California State Assembly. And closer to home, we are happy to have Joanne Simon of the New York State Assembly and Anastasia Somoza from the Office of the New York City Council Speaker. Joanne and Anastasia have been great friends of NYU and longtime champions for people with disabilities. And we're also joined today by a number of business leaders from the private sector, including Stan Bergman, the CEO of Henry Schein Inc., which has greatly supported NYU's efforts to expand access to quality oral health care. The presence of the entire slate of distinguished speakers convening today underscores the urgency and the importance of this issue. NYU has been proud to be a leader in this area, and we look forward with all of you, panelists and participants, to advancing the conversation even further today. Thank you all for being part of today's event. Thank you all for your participation, your insights, your comments, and especially your commitment to this important issue. Thank you.
Thank you so much, Andy. I really, really appreciate it. You can see the level of enthusiasm that we have in the Central University that makes so much of what has been going on in the dental school possible. Now it's my pleasure to introduce Dr. Timothy Shriver, Chairman of the Special Olympics. Dr. Shriver is a social leader, educator, activist, film producer, entrepreneur. As Chairman of the Special Olympics, he serves more than 3 million athletes in 180 countries, thereby promoting health, education, and a more unified world through the joy of sports. He's also co-founder and current chair of CASTLE, the Collaborative for Academic, Social, and Emotional Learning, the leading research organization in the United States in the field of social and emotional learning. Please join me in welcoming Dr. Shriver.
Thank you, Charles, and I apologize that I had a little trouble getting in, but here I am, and I'm delighted to be joining all of you and be delighted to be included really in this almost, I'd say, historic gathering, not because we're on Zoom for the 4,000th time. Most of you are probably on Zoom for the 4,000th time, even maybe the second or third time today, but because of the topic and because of the gathering of leaders and because of the importance and urgency of our work now. I just want to start by inviting each of us to remember that we are in a time when, amidst all the things we know, the pandemic, the division, the racism, the reckonings, the extraordinary inequalities that have been revealed, we are in a time probably unprecedented, certainly in modern history, certainly in modern American history, where new ideas and new normals are possible. There is a lot of use of the word normal, return to normal. And for many people, I understand completely why they say that, because what we're living in now is so extraordinarily painful and difficult and disastrous in many respects. But at the same time, I want to remind us, we have an extraordinary moment in which the normal can be redefined, that more possibility is on the table than probably at any other time, that we don't have to go back to where we were, complaining, bemoaning, decrying the absence of possibilities of change. We are in a moment where change is radically possible, but it's not going to happen on its own. And so the reason I'm so excited about this gathering is because I think after a couple of hours of these discussions, hopefully people will leave imbued with the energy to say, I am going to be an ambassador, an agent of change in the new normal. I am going to create not what we had, but what we need. Not what we used to live in, but what we should live in. Not where we were, but where we want to be. And when it comes to people with intellectual disabilities, this call is urgent. So let me just take a few minutes to give you a little bit of a sense of why me. My training is as a teacher, as an educator, and then after many years in education, moved into the Special Olympics field. What do I know about dentistry? Nothing, honestly speaking, or almost nothing. What do I know about health? It's limited. So why am I here? What is the Special Olympics movement? Many of you are thinking, well, that's a track meet or a soccer game, or that's something we do on a Saturday afternoon in the middle of the spring. What are we doing in the business of health? So let me just give you a little sense of how we got here, and some of the speakers and people you'll hear from later will give you this in more detail. But this is a picture of Ives Green. He lost his life. He was the first person to die of COVID-19 in the state of Louisiana, living in a group home. His family, on the occasion of his death, made this remark that you see on the screen. He had a lot more living to do. And the picture of Ives, this man full of life, this man who loved being a Special Olympics athlete, this man who obviously infused the room in which he was in with an energy and a joy and a goodness, has stayed with me. Why? Because in some ways, he's a reminder of the millions of people with intellectual disabilities who come into the healthcare system and find it unwelcoming, who come into the healthcare system looking to live their lives fully, but meet a system that doesn't expect or invite them to live their lives fully. Ives probably could have been saved had he not had an intellectual disability, because he probably would have gotten better care, quicker responses. He probably would have lived in a place that didn't have as much of a chance of the contagion spreading. But over and over and over again, millions of athletes who come into the Special Olympics movement come to us, and we have found over the years, they come to us sick. Not sick from their diagnosis, but sick from preventable disease, neglected care, the absence of primary prevention. They come to us to play soccer or to run track or to swim in the pool, to raise their arms in victory, to try to win their medal, to prove to the world that they count, and they come to us, and over and over and over and over again, we find them sick. And it was in the late 90s when my colleague, who you'll hear from momentarily, Dr. Steve Perlman, and his great friend and our former great leader, Dr. Paul Berman, came to us and said during a Special Olympics World Games, we want to actually provide some clinical education and some screening services to the athletes at your World Games. These are Rhodes Scholar-like athletes. And what do they find after 5 or 6 days of screening athletes randomly? Extraordinary levels of disease and preventable, curable problems that had been neglected by the system. And it was at that point that we in the Special Olympics movement said, we've seen enough. Taking our athletes from the track or from the swimming pool down to the emergency room because they had such extraordinary levels of oral disease was enough for us to say, we as a public health movement, we as a social change movement, we as a fitness, nutrition, participation, community building movement have to take a stand on healthcare issues. So what do we find even today? Here's the kind of oversimplified statistics. If you took a group of 10 Special Olympics athletes, and there's nothing here that makes me proud of our organization or proud of our country, honestly. Proud of the healthcare system, proud of myself. I'm not pointing the finger here. We point the finger at ourselves first in our movement. This data is an indictment of us. but we welcome it in some ways because it is a challenge to and a reminder of the urgency we all should feel in addressing these issues. Almost 80% of our athletes are overweight or obese. 1 in 10 or more needs an urgent referral to a dentist. 30% almost will fail a hearing test, and you see the statistics here. These are all statistics that have to do with failed systems and communities and families and structures and schools, the whole system. Everything here, almost everything here, could be reversed without enormous difficulty if we had a highly functioning public health, clinical education, I'll say more about this in a minute, system that cared deeply about the quality of life, about the living that the Special Olympics athletes of our country have yet to do. So recently, this report was issued, The Missing Billion. So this is just a reminder, my friends, that while the numbers of people with intellectual or developmental differences are quite small as a function of the overall population, important but small, the larger agenda of inclusivity when it comes to people with disabilities affects 1 billion people. And it's, don't take this from my point of view as maybe an advocate for people with intellectual disabilities, take it from the point of view of the scientists, the American Journal of Public Health, and that this is 1 billion people worldwide who are getting substandard services. And we were as a movement, very happy to participate in this report. There are so many barriers that are preventable. What do we hear? We hear over and over again from healthcare professionals, I was not trained to care for this population. We hear over and over again that from our athletes in their communities, primary prevention and fitness is not promoted for this population. Communication, access, clinical interactions are broken down for people with intellectual disabilities. That it's not user-friendly, the policies aren't inclusive, the reimbursements aren't fair, the insurance and governance systems don't advocate for this population. So we see multiple barriers. But again, all of these are correctable in a new normal. Here's what it looks like. And again, many of you will know this journey. A person with an intellectual or a developmental difference finds themselves experiencing some kind of discomfort or pain. The first problem is they can't find a dentist. Second problem is the dentist might not be nearby. The next problem is they might not be able to afford it, and the reimbursement systems don't incentivize the dentist to provide the care. The next problem is oftentimes, even if all those other things are addressed, the dentist might not feel comfortable, or the oral health team might not be trained, might not be adequate, might not be up to the task of providing care to this particular person. And then the systems of support needed for medication and supports after care are also missing. So if you look at this, there are steps along the way, and almost every step we are likely to lose people and they drop out of the system. So what are we doing? In the Special Olympics movement, we have several programs. We call them Healthy Athletes, Healthy Communities. Many of you, of course, know these. Healthy Athletes has been going on now for over 20 years. We've done 2 million screenings around the world, over 5,000 screening events. These are screenings right in the midst of games and competition. Tents are set up, rooms are allocated, machinery's brought in, and now analytics are brought in, volunteers are trained, clinical professionals are brought in to run these screenings. So we've trained 150,000 healthcare professionals in these screenings. And these are frequently people with great seniority who have positions of prestige in their professions, in their hospitals, in their clinical settings, but they've never had a full day of looking into the oral cavity, looking into the mouth of people with intellectual disabilities. And they walk away going, oh my God, now I know what I'm doing. We also have this Healthy Communities movement, which is to try to support, once we identify athletes, people with intellectual differences who need help, how do we build the follow-up systems of support so that that person's likely to be able to navigate that maze in the previous chart. And now what we're calling inclusive health, a movement to actually expand training and systematize the changes in the curriculum and the changes in the supports needed for people with intellectual disabilities in the training systems and in the healthcare system. So, you know, this is one of a picture that's some years old now, but this is something, again, many of you as dentists will have seen. James Pierce on the left, I think he was 41 years old when this picture was taken. This is the standard of care on the left. Sorry to say, oral care. This is a person in the United States of America in the 21st century. This is the kind of healthcare he got. This is the kind of oral health dentistry he got. And the picture on the right is not photoshopped. It's our great friend Rick Rader took these pictures because he's a committed, trained, motivated, if I dare say it that way. He's a man, a dentist, who's committed to this population. So when James came in, Dr. Rader saw the chance to make somebody's oral health great. For you, I mean, to me, this looks like a miracle. To those of you in this audience, this probably looks like, of course I know how to do that. Why don't I get the chance? Why don't I get reimbursed? Why don't I see these patients? Why don't they come regularly? That's what we're about here today. So, you know, the Special Smiles, which is one piece of that overall Healthy Athletes movement, if I can put it that way, done 150,000 oral health screenings in the past 5 years alone. And after these screenings, after the education that comes with these screenings, you see the data. 67% no longer have mouth pain after the screening. And over almost a third don't need urgent referrals after these screenings. So, you know, these are, again, it's not, maybe it is rocket science in some ways because it's social change. It's not scientifically complex to address these issues. It is politically, socially, culturally, professionally complex to shift the systems so they provide this kind of care. So let me just give you a couple of very quick examples, and I know I'm probably running over time, but I just want you to know that you have colleagues around the world, not just in your own. There's Stacy, you can see her picture there in your own backyard. But on the left, you see Dr. Rina Kumar, who was a disciple of our colleague, Steve Perlman. But on her own, having been exposed to this population, having been exposed to the challenge, having been brought in and educated by Steve and others about the challenge, has taken on really the entire country of India, 1 billion people. I mean, it's an extraordinary, and these numbers are verifiable. She has mobilized thousands and thousands of dentists and oral health professionals to provide free dental care to people with intellectual disabilities across her nation. It's not going to maybe be a headline in the New York Times, although it should be. That's another story. Don't get me going on the press these days. But she's a hero, and she's creating a new normal. Same thing in Kenya. You see there Ann Costello of the Golisano Foundation, our great partners who have made so much of this work possible, opening a new center in Kenya Lions Sight First Eye Hospital, including medical, dental, diabetic treatment, so on and so forth, dedicated to people with intellectual disabilities so they get the care they deserve from professionals who are committed to them. Again, you see on the right there, you'll hear much more about your own work at NYU. But, you know, this is not a problem with the developing world. It is a problem in the developing world, but it's not a problem limited to the developing world. This is in our backyard, too. I'm glad, Stacy, you're on camera so I can see you looking at yourself. Hi. So, you know, we've got work to do. Our vision, our partnership with you, envisions a new expert workforce. What we're tentatively calling, we look forward to your feedback on this, professors of inclusive health. And those professors that we want to recruit will all be people with an intellectual difference. Because the best way to train healthcare professionals about intellectual disabilities is to train healthcare professionals by people with intellectual differences. So we envision unleashing a new faculty that would be able to work with dental and medical schools and other health training centers to do firsthand, frontline. Here I am, I'm a person with Down syndrome, I'm a person with autism, I'm a person with whatever syndrome. Here's what I need. Here's how you care for me. Here's the science even behind my difference. We envision a much more aggressive effort in the coming years to capture the data that allows us to make the case. We've got good data, it's not great data. We need great data to transform public policy. And we're committing ourselves to trying to become partners in a larger survey system around longitudinal tracking of the health status of people with intellectual differences in our country. We envision a new generation of digital supports for families from cradle right up to grave, digital supports that can provide training on health, on fitness, on nutrition, on primary prevention, on clinical supports for people with intellectual disabilities. And of course, teledentistry, we're just getting started as a country, as a world, but we believe this could be fantastic for our population where sometimes the needs are quite complex. And maybe there's a specialist here or a specialist there, but not in your neighborhood. Who knows what might be possible if we are able to stay on top of this. Let me close with just this picture. This is Dustin Plunkett, a Special Olympics athlete. He will tell his own story better in this video, but I just invite you to look at that smile, see a man who is not just an athlete, but has become a commentator on ESPN, and not just a commentator on ESPN, but a public speaker in front of presidents of the United States and other countries, an advocate, a decent, caring human being who has a lot of living to do. Thank God, his life, unlike Ives Green, was saved by a dentist. His life was saved by a dentist at the side of a Special Olympics screening and then later in a clinical setting. The idea that we should allow any life like his to be treated with less humanity, less decency, less integrity, less dignity than any other is part of the old normal. I hope that the new normal is all of us working together to change that. I think you guys have the video, so I'll stop here and let's run the video.
Couldn't afford the services or both.
As for me, I would have died if it wasn't for Healthy Athletes and Dr. Steve Perlman. My name is Dustin Plunkett. I had not seen a dentist for 10 years, and in 2004, I went to Healthy Athletes and got my teeth screened by a volunteer dentist. He discovered that I had gum cancer growing in the upper left side of my mouth. I was able to make a full recovery, and my team and I went on to win the silver medal at the USA Games in Seattle.
Dustin Plunkett diagnosed with an oral cancer that would have taken his life had he not been seen. There are hundreds of lives that have been saved, hundreds of thousands of lives that have been improved, millions of lives that have been changed.
We've got to do everything we can to help prepare that athlete to live a longer, healthier, more fruitful life.
Since 1997, Healthy Athletes has trained more than 260,000 healthcare professionals and students. They provide life-changing screenings, as well as services such as prescription glasses and hearing aids.
I've been there when I've seen a 20-year-old athlete see them get a pair of glasses and see their mother for the first time. I've been there with an athlete received a hearing aid and actually heard somebody for the first time. It hits you right in the face why our program is so important.
So thank you. You can see I had a better haircut back in those days when pre-COVID you could get your hair cut. But thank you all for allowing me to barge into this very important meeting. Thank you to the speakers who will follow me. I know Neil and Steve will be terrific. And thank you for being committed to, as I say, what I hope is a new normal for all of us, professionals and patients alike. Thank you.
Dr. Shriver, thank you so much for a really inspirational start to this session. If people were not inspired before, they will be now. I have no doubt about that. So thank you so much. And the opportunity to inspire is also associated with our next speaker. And so it's a pleasure for me to introduce Dr. Stephen Perlman. Dr. Perlman is Global Clinical Director and founder of Special Olympics Special Smiles and Clinical Professor of Clinical Dentistry at Boston University School of Dental Medicine. For the past 40 years, he's devoted much of his private practice as well as his teaching to the treatment of children and adults with physical and intellectual disabilities. Dr. Perlman, please thank you. Let me thank you for taking on this assignment, and join me now in welcoming Dr. Stephen Perlman.
Hi, am I good?
Looks good to me. You're coming through clearly.
Thanks. Am I on?
Yes, yes, you're fine.
Okay. Thanks, everyone. Thank you so much for inviting me to participate in this exciting day, highlighting healthcare for children, adults, and all people with disabilities. I have had the pleasure of working with Dr. Shriver for over 25 years, and Neil Romano for almost as long. I couldn't be more pleased than to speak in between them, because it gives me the opportunity to thank them for their help and support that has enabled us to move the bar to improve healthcare for this most medically and dentally underserved population. I want to use my time to share with you my journey when I started working with Eunice Kennedy Shriver, Tim, and Special Olympics. When Special Olympics decided to become the world's leading advocate in healthcare for people with intellectual disabilities, the first thing we needed to do was to demonstrate the need and show that these huge disparities in healthcare existed. So in 1999, Tim went to Yale University, the School of Public Health, and met with giants Ed Ziegler and Sarah Horowitz, and hired them to do the most complete literature review ever on health disparities for people with intellectual disabilities. This report, which was released in September 2000, look at it. This is the original Yale report. This is everything that we knew about healthcare for people with intellectual disabilities. It's 158 pages. That's it. It demonstrated that we know nothing about the healthcare. As a country, we knew nothing about the healthcare of people with intellectual disabilities. We took this document and presented it to Congress, and with the power and using Special Olympics as the bully pulpit and the soapbox, we got the first ever congressional hearing on health disparities for people with intellectual disabilities. This is the report of the Senate hearing. It was held on March 5th, 2001 at the Special Olympics World Winter Games in Anchorage, Alaska. This was amazing, and it showed, as Tim said, that advocacy can work. Getting the documentation that the disparities existed, and then having the resources and the advocacy to be able to get this Senate hearing. At that Senate hearing, we were able to get FaceTime with Surgeon General David Satcher and indicted him for allowing these health disparities to exist in this country. And so the Surgeon General agreed to have the first ever Surgeon General's Conference on health disparities and mental retardation, it was called, December 5th and December 6th in 2001. As I sat there, I couldn't believe that our work in Special Olympics was solely responsible for this meeting, and Surgeon General Satcher presented the highest medal that he could give to Eunice Kennedy Shriver and told all the people in attendance, and it was the who's who, the first time that all these federal agencies were brought in, maternal and child care, CDC, NIH, NIDCR, the LEN programs, the USAID programs, the university centers of all the people in the country to sit together in a room for 2 days and try to improve healthcare for people with intellectual disabilities. And that conference was a huge turning point and the next milestone in the health movement of Special Olympics. Because after that conference, I started to get calls from people all over the United States, physicians, dentists. Steve, I'm a neurologist in New Jersey. I met you. I'm an expert in seizures. I want to work with you. I'm an anesthesiologist in Arkansas, and I'm an expert in craniofacial anomalies. I want to work with you. And so after the Surgeon General's Conference, many of us got together and formed the American Academy of Developmental Medicine and Dentistry. So now we had an army of leading experts in medicine, in dentistry, in nursing, and other allied professionals, because I realized that in Special Olympics, we only had 8 health disciplines. There are over 200 specialties in medicine. We needed the mitochondrial experts, the metabolic experts, the geneticists, the pediatric cardiologists, and everybody else. We needed them. And so now we have an army behind us in this movement. And I'm proud to say that as of this date, we have over 30 student chapters of AADMD in medical and dental schools throughout the country. And we're changing through a grant from CDC to Special Olympics. AADMD is changing the curriculum, and over 20 medical schools are engaged in changing the curriculum based on our work and help. About the same time, Dr. Barry Waldman, a distinguished teaching professor at Stony Brook University, came to me and said, you know, Steve, the reason why dentists are not being trained is because there's nothing in the CODA, in the Council on Dental Accreditation, that says that dental schools have any obligation to train dentists. So Eunice Kennedy Shriver, myself, and Dr. Waldman approached CODA and wrote a letter petitioning them that this had been a mistake, that there had to be, that there was no obligation of dental schools to educate healthcare professionals in the treatment of patients with special needs. And so we petitioned CODA. It took us 2 years to get it passed. And the reason being that the dental schools claimed that there was no faculty to teach it, and the levels of reimbursement was so poor that the schools couldn't survive on the income from it. But in July of 2004, CODA passed the first regulation that dental students and hygiene students had to be competent in only diagnosis and treatment planning. They wouldn't commit to treatment, but at least we got a foot in the door, and dental students' obligation, diagnosis, and treatment planning. In 2005, we were invited to testify before the President's Committee for People with Intellectual Disabilities. Tim, Rick, Matt, 3 of you were with me when we testified before the President's Committee. It was called Keeping the Charge, Accessibility for Dental Care for People with Intellectual Disabilities. This white paper was produced after our testimony, and I want to quote, as a report of our findings, the committee is submitting a report citing the deplorable status of dental care for American citizens with intellectual disabilities. The members of this committee, all appointed by you, Mr. President, are deeply concerned about the issue as described in this report and have suggested recommendations for your consideration and possible action. Sadly, what has changed since 2005 when the President's Committee submitted this report? Medically underserved issue. Our own Dr. Matt Holder, who's going to talk later, discovered as a graduating physician, he wanted to work he didn't want to work in a public health facility that dealt, he wanted to work in a developmental center, and he discovered that people with intellectual disabilities are not a medically underserved population, even though we had proven, documented, and demonstrated to the federal government that people with intellectual disabilities are the most medically and dentally underserved population. In the eyes of the federal government, they still are not. And so the federal government refused to designate people with intellectual disabilities as a medically underserved population. So through the AADMD and Special Olympics, we petitioned the American Medical Association, and in 2010, the AMA officially passed a declaration that declared people with intellectual disabilities a medically underserved population. We went to the American Dental Association then, and we asked them that since the AMA passed it, and access to medical care is so much easier than dental care because of the hospital emergency rooms and the system that they have and the safety nets that are available for medical care. I knew the American Dental Association was going to give me a problem because they didn't want to admit an access to care problem. But it took us 4 years after the AMA approved it. But in 2014, the American Dental Association officially declared people with intellectual disabilities a medically underserved population. And so that does exist today. And the Heads Up Act, now, where is this? Still, the federal government will not declare people with ID a medically underserved population, but there's now a bill before Congress that we all can support called the Heads Up Act, which will approve them as a medically underserved population, which will have so many ramifications, including very significant loan repayment for healthcare professionals that want to work with this population. And now, in 2019, thanks to the leadership of Neil Romano and the National Council on Disability, we were able to convince the American Dental Association to revise the principles of the ethics and the code of professional conduct. For too many years, for almost 40 years, I've heard that the access to dental care is impossible because dentists claim that they don't treat, they got no education in dental school. And that's why they don't feel comfortable in treating patients with special healthcare needs. But now, thanks to Neil and the committee's work, the Code of Ethics of the dental profession now reads, while dentists in serving the public may exercise reasonable discretion in selecting patients for their practice, dentists shall not refuse to accept patients into their practice or deny dental services to patients because of the patient's race, creed, color, gender, sexual orientation, gender identity, national origin, or disability. Thank you, Council on Disabilities, for having the strength and the passion and the commitment to indict the profession to change the Code of Ethics. And now, because disability is in the Code of Ethics of the profession, CODA has to change and is changing its regulations that dentists have to be competent in treating patients with a disability. Thank you, Neil. This could never have happened without your and the council's support. I could go on and on about the accomplishments of our Healthy Athletes program and the work that we do and the amazing volunteerism and the support of my army of AADMD members. But I just want to tell everybody, thank you everybody, and Special Olympics and the AADMD welcome you to join us to help achieve health equity for patients with disabilities. Thank you.
Thank you so much, Dr. Perlman, for an incredible and really sobering presentation. There's lessons there for all of us. And you have done a wonderful lead-in to our next presenter. So it is at this point my pleasure to introduce our keynote speaker, Mr. Neil Romano, who you've heard about. Mr. Romano is chairman of the National Council on Disability, an independent, nonpartisan federal agency that advises the President, Congress, and other federal agencies on disability policy. Chairman Romano came to his current position following many years as an advocate for people with disabilities, serving on the President's Committee for People with Intellectual Disabilities from 2006 to 2008, and as Assistant Secretary of Labor in the Office of Disability Employment Policy from 2008 to 2009. His passion for expanding access to the full range of opportunities for people with disabilities stems from being an individual with a disability himself, namely dyslexia, the stigma he's battled throughout his life. That experience shaped a philosophy that's based on the premise and the belief that people with disabilities should have equal access and care in all areas, and that disability rights are actually civil rights. So please let me add, just as a little note, that Chairman Romano is also a graduate of NYU's College of Arts and Sciences, and ask everybody to join me now in welcoming Chairman Romano.
I am having a little problem.
I am seeing you very well, Mr. Romano,
Can you hear me, sir?
and I can hear you very
Okay,
clearly.
then
So
let's
set.
begin. Thank you very much, Dean Bertolami. I really appreciate that. You know, right now I'm sitting here a little bit confused by the by the nice things that Dr. Perlman has said this morning about me and about the work of the council. Quite honestly, if I can go back a little bit, I have to tell you that in 2017, one of my council members, actually my vice chair, Jim Brett from Massachusetts, and I were having a conversation, and we were talking about people with disabilities as it related to their health care. And he said, you know, Neil, he said, I'd like you to meet a gentleman by the name of Dr. Steve Perlman, which of course, I immediately exploded in laughter. I said, I've known Steve for 20 years. I said, he's one of my mentors. He's one of the people who basically taught me what it means to be without care. He's the one who showed me the things that Special Olympics was doing. And I made a commitment from that point on that when I worked in the disability field, that would be a very important issue of mine. Well, in 2017, I became the chairman of the National Council on Disabilities. For those of you out there who don't know what that is an independent federal agency that's responsible to report to the president and the Congress about all things disability. We consider ourselves, amongst ourselves, we're the people who are basically responsible to make sure that the government is living up to or keeping the promise of the Americans with Disabilities Act. I mean, that's what we say when we're being formal, but when I'm talking to my friends and people like yourselves today who I really appreciate for the work you're doing, I call us the government scutches. We're the ones that look at every government program and we go into whether it's justice or labor or whomever it is, and we say, you haven't considered people with disabilities. Have you considered them in this? And for the council, that's a role that's really important. So we decided in 2017 to take on the issue of healthcare and especially dental care. And quite frankly, everything that Dr. Perlman ran through today, all of the improvements were done in conjunction with him and his folks. But NCD really put their back into saying, this is not fair and it's not right. You know, you did mention, Dean, that I am a graduate of New York University, and I have to tell you, I spent 3 of my worst years at NYU, as I am a person with a disability. I have dyslexia, and I spent a good deal of my time crying in the Bopst library as I tried to complete all my assignments on time. But I have to tell you, my liberal arts education has been nothing short of amazing for me to really get a good look at the world. But the fact of the matter is this, that there are so many people with disabilities that don't have the opportunities that we have. And what we're seeing in the medical field, sometimes more often than not, is absolutely outrageous. You know, there's not a lot of good things that we can say about this pandemic. But I will tell you one thing that it has really done that is beneficial to those of us in the disability community, those of us who care about folks with disabilities. And that's, it's put a sharp focus, a bright light on the fact that people with disabilities are wholly underserved in just about every area. You know, ADA was passed 30 years ago, but this pandemic has demonstrated to us that there are huge holes in every aspect of life, and the biggest hole falls in the area of healthcare. You know, for the past 6 months, as the chairman of NCD, I'm almost embarrassed to say that I've spent a good deal of my time trying to convince the medical community and working in conjunction with the United States Department of Health and Human Services Office of Civil Rights to develop and put out warnings and to put out papers saying, don't forget, during this pandemic, we are responsible to take care of people with disabilities the same as any other group. Is that absolutely outrageous that we have to remind people that they're supposed to treat people equally? And not just because it's the right thing to do, but it's also the law, and we still have to tell them to do that. It's interesting, during the pandemic, we heard of states who had emergency planning that did not include people with disabilities in their plans. I actually sat down and spoke with a head of the emergency planning for a state that said clearly that they would not treat people with intellectual disabilities, and they would be put to the very end of the treatment schedules. We couldn't believe it. I had the conversations with them, and only to find out that, as I would have suspected, that they never included anyone with a disability in their plannings. I can guarantee you they never had a Dr. Perlman. I can guarantee you they never consulted with a Dr. Rader or any of the other great folks that are also going to be on the panels today and that are going to speak. You know, when I was preparing for this and I was just mentioning about NYU, I spent a little time going through NYU's dental school for people with disabilities, the clinic, and I read about it. And the thing that struck me in all of the things I read was this one very simple sentence that pretty much sums it up for where we're all supposed to be. NYU Dental Oral Health Care Center for People with Disabilities on their website said this: we provide care, based upon a deep commitment to assuring disabled patients, their families, and caregivers that they aren't just cared for, but cared about. Think about that for a minute. Think about the important differences between being cared for and being cared about. I have to say that if we took the time to care for the people in front of us, the way the people at Special Olympics care for, respect the people that they're dealing with, the people they're working with, that we wouldn't have health inequities. How could you possibly do that? How could you have care? How could you, well, I'm going to use a very ungovernmental word, I'm sorry. How could you care about, how could you love people and treat them differently and see images like we saw on TV that Dr. Shriver showed us and not have it burn a hole in your heart and in your conscience? For those of us at NCD, that's our business every day. But every single time we have a conversation, every time we talk privately, we always remind each other that it's not about the thousands and millions and the 61 million Americans with disabilities in America that we're working for, even though we are. We're working for that one person. We work every day with the person in mind that we saw or met or cared about. You know, I know a good deal about dentistry because I've had a 30-year career of working with dentists. And I have to tell you, it has been, quite frankly, I'm just going to say it the way it is, it's been a blessing in my life. I have never met people who were more caring or concerned about folks and who were so willing to give. 25 years ago, I started a program called the National Spit Tobacco Education Program, or NSTEP. And my biggest problem was we were working to examine baseball players and people for oral cancer. And my biggest problem was that we were calling for dentists to help us and to go into baseball, minor league baseball complexes and examine for oral cancer. My problem was in asking dentists to come was not getting them. It was the numbers that I got. So I have a pretty good idea what the dental community is like. They're a caring group. So when we hear some of these things, we understand clearly that, you know, the problems people have, it's not the dentists, it's the lack of training. It's the lack of understanding what their responsibilities are. And I think working harder in those areas is important. You know, I come to this with a little bit even more of a background than that. I had a cousin who lived with me by the name of Mary. And Mary was a young lady at the time when we were growing up together who had ID. And she was a lovely, charming, pretty young girl who my parents raised. And it came that day when she went to the dentist for the first time. And I just have to tell you that it still breaks my heart, and it's hard for me to even talk about because I can feel tears coming to my eyes. When she came home one day at 14, they had removed all of her teeth. They told us, they convinced my family that that was the best route for her, that she'd be better off without teeth. Those are the kinds of things that are in the back of my mind and in the back of NCD's mind as we work on stuff. The fact that these things do happen and we have to prevent them. You know, I was beginning to say that when we talk about civil rights and when we talk about medicine and dentistry, when I hear that people don't plan for, when I am encouraged though by what the American Dental Association has done and what has happened with CODA that Steve Perlman went through very carefully, I am happy about it, obviously, but we have a long way to go. We really have a lot that needs to be done. That's just really the beginning, because now we're waiting for a generation of dentists to learn this. But frankly, we really don't have the right to wait. We don't have the time to wait. Because you see, like some of the folks Dr. Shriver showed us in his video, they're there. They're there now. And with all the advancements we're making and everything we've been talking about here today and all the wonderful things that have been done, there are still too many people out there who are not getting equal treatment. You know, equality is a strange word. There's no modifier for it. You're not more equal or less equal. You're just equal. And if you're not equal, you're simply not equal. And that can't be overcome unless we all work on it together. You know, I find it fascinating that we have so many people who are unaware even of the facts around the Americans with Americans with Disability Act, with ADA. I continually get confused between ADA and ADA. Forgive me, it is indeed true that I have dyslexia and that there are times that I confuse things like that. But anyway, it is fascinating to me that when I speak to people in the medical field, not just the dental field, but the medical field in general, they're not aware of the fact that small offices to large offices in every field of medicine are subject to the rules of the Americans with Disabilities Act. All doctors in this country, regardless of the size, regardless of the number of chairs, regardless of the number of rooms, operatories, they're all ruled by and governed by the Americans with Disabilities Act. Now, it's just stunning that under those conditions, we still find out that we have the vast number. We're not even talking about being able to take care of specialized patients, but the vast number of practices, both dental and general medicine, that are not even equipped to have people in wheelchairs come into their office. This is a crime. This is really a tremendous shame. You know, we are talking today about, you know, we have had a focus and we are talking about dentistry and people with intellectual disabilities, but I think it's really incumbent upon me as the chairman of NCD to tell you that it's much richer and deeper than that. We can hear a lot of good things that are going on, but let me tell you, it's not that good out there. Right now, and this should really burn a hole into everyone's heart today, if you are a person in a wheelchair in America, if you are a man in a wheelchair, you have only a 50% chance, 50% chance of ever being examined from the waist down. That means that if you are a man, you never get you have a 50% chance of ever getting a digital prostate exam. That to me is horrifying. And why? Because most doctors do not have articulating tables, accessible equipment to be able to move a person from a wheelchair to a table to be able to examine them correctly. You know, I had a brother who was a quadriplegic from the Vietnam War, and happiest guy I ever met. Felt lucky to be alive, had a great day every day. But I know as a fact that he never had a digital exam. And actually, when he passed away, among the myriad of problems he had was that they found out that he also had prostate cancer. This is horrifying in America. We're not talking about Medicare patients. We're not talking about people who can't afford, let's say, and you say, well, they can't, you know, it's not. No, these are people who are covered. These are people who can, but people who are simply forgotten or overlooked. Women in America. If you're a woman in a wheelchair, you have less than a 55% chance of ever getting a breast examination because they don't have the equipment, the articulating tables and things to lift a woman up out of the wheelchair and go and have a breast exam. This is horrifying. Can you imagine if that was generally known to people, how terrible that would be? Don't these folks have the same right to medicine as everyone else? Good medicine, quality medicine. NCD right now is in the process of doing an assessment of what offices, how many people have accessible medical equipment. One of the things that really shocked me was that less than 1 in 100 medical offices have a wheelchair accessible scale. So what does that mean? That means that patients go in and don't get weighed. Now, some of you, you know I have dyslexia, but some of you also know that I have leukemia. There was a point during my treatment and my care where I needed to be weighed constantly for my chemotherapy. I have to tell you, there were a couple of hospitals I went to and a couple of offices that couldn't do it. I had to go to a specialized place to get weighed correctly because the amount of chemotherapy involved with a person's weight. Think about that for a moment. Think about the losses that go on. But let's get back for a moment to dentistry, because this is really, for me, dentistry really touches my heart because, as I said, I've known dentists for a long time, worked in the field. I have been blessed by knowing people like Dr. Perlman. And by the way, I've mentioned Dr. Rick Rader. And one of the great things that I get to tell you today, beyond all the other things that we've had the opportunity at NCD to do, is that I would like to tell you all that the President of the United States has nominated Rick to be a member of NCD, which should be great news for all of us, because no matter how long I'm there, whether I'm gone soon or whether my chairmanship is over, which it should be soon, Rick will still be there. And I know that in the area of access to healthcare, I mean, you don't get more energetic than Rick. So we're very, very proud of that. But we were talking about, Dr. Perlman was talking about, he's talking about NCD and some of the things that we're doing. The fact of the matter is that there's a lot more to be done. We hear a great deal about things and NCD that need to be done. And the Heads Up Act that was mentioned by Dr. Perlman is particularly important because it would designate nationally it's really exciting that the AMA and the ADA have designated people with ID as a special population. But until the federal government gets around to doing that, reimbursements and the costs of things are not going to change. Until we do that, until we fight hard to get that done, we have to make absolutely sure that we work on that, because that is the only way that we're going to open up the kind of funding and opportunity that's going to change care for people with disabilities in America geometrically. That is the biggest next jump we can possibly make. That, of course, and the education of people of the medical community about their responsibilities under the American with Disability Act. You know, I mentioned that I've had the opportunity to work in dentistry, and that I had done a program with Major League Baseball about oral cancer. And one of the reasons why I'm here with you today is because when I first started my program in baseball, I was engaged by Steve Kess, who I'm sure almost everyone here knows. He heard about our program, and he was on a group called Oral Health America that I became a part of. And it was at that time that I met Steve Kess and learned about the Henry Schein Corporation. I have to tell you something. Sometimes you're a little bit concerned when you get approached to do things with corporations, because you wonder, well, what's the motive? What do they want to do? Well, I'll tell you. We worked on that program for years, and the motivation was to help people. I have never worked with a company that wanted to help people more. Frankly, when we started working on this whole program, one of the first people I approached was Steve Kess about all of this medical inequity. And I sat down with him. I remember it was a few years ago, we sat down and we had lunch. And before I could finish my presentation about health inequity, about the lack of accessible equipment, about the need to push some of these things, Steve already had about 25 ideas about how we could go on and do this. And I am very, very proud to say that the National Council on Disability has developed a partnership with the Henry Schein Foundation and Henry Schein to bring to the American people this message, to bring to the medical community this message about their responsibilities, but also the value of what they're doing. You know, at NCD right now, we're doing a study about the economic value of working, of increasing the payments to doctors for these treatments. Well, frankly, between you and I think it's silly, because we don't need to talk about the economic value of that. If we don't understand yet that if we can't take care of a dental patient or a medical patient early in their disease process, that we're going to pay 10 times more at the other end, and the government's going to have to pay it. And if they're going to continue to be short-sighted about that, well, then we're going to continue to get poor health care in that regard. So we need to keep fighting in that direction. But on the other hand, doctors need to understand, general practitioners, even more so than dentists, because dentists have been getting it. As you can hear from some of the things we heard, we need to fight on and on in those areas so they understand their obligations under ADA. As I mentioned before, ADA, it makes every office of public accommodation. That basically means that you're subject to the laws of ADA. And as I've said to doctors many times, there is going to come a point where the Department of Justice is going to make a decision that they're going to begin prosecutions for people who don't. And the good thing to do is to get ahead of it. The folks at Henry Schein understand this. And I have to tell you, I had the pleasure of having a conversation with Stan Bergman at a thing we did at a dental meeting. And I mentioned him, I said, you know, Mr. Bergman, in the final analysis, this is also going to be good for, you know, for dentists, for business, across the board. And he grabbed me by the sleeve and he looked me in the eye and he said, you know, Neil, it's all about people. It's not about profit. And I have to tell you, that's what it is. That's what the NYU Dental School is saying. That's what Special Olympics is saying. That's what all of you who work so hard every day here are saying. It's not about profit. It's not about that. We want you to do well. I want to fight for reimbursements that are better for you. But the fact of the matter is, it's for people. You know, I never give a talk without reminding people that the Declaration of Independence is my favorite federal document. It's kind of weird to have one, but I have one. The part in there that says that all men are created equal and they're entitled and they're endowed by their creator with certain inalienable rights, and that among these are life, liberty, and the pursuit of happiness. When they wrote that, trust me, the founders knew well that they were slaves. They knew women couldn't vote. They knew people who didn't own property couldn't vote. But what did that mean to us as Americans? Not just as doctors, as Americans. It means we have a responsibility. It means that's the check they wrote on the country of what they wanted, what their dreams were for America. And what you are doing here, what we are struggling to do to make sure that every American gets access to good care, is part and parcel of that goal, to make every American equal. So thank you very much for your work, and God bless you.
Mr. Romano, thank you so much for a really amazing keynote address. I've learned so much from our speakers this morning on the need for clinical care, of course, but also the need for those of us in dental schools to provide the education for the next generation of dentists, and of course, policy and advocacy, without which none of this can materialize. So thank you so much, and we'll now move on to the rest of the program.
Thank you, Dr. Bertolami, and thank you, Chairman Romano, and all of this morning's distinguished speakers. I'm Dr. Stacy Ripke, Associate Dean for Student Affairs and Academic Support Services at NYU College of Dentistry, and it is my privilege to introduce the panel discussion portion of today's program. Please feel free to submit questions for the panelists using the Q&A function on this webinar. We will address them as time permits. Questions are being archived, and with resources will be linked on our AHEAD website next week, as will the recording of today's symposium. It is now my great pleasure to introduce NYU College of Dentistry's Executive Vice Dean for Administration, Development, Finance, Student Affairs, and Clinical Services, as well as co-chair of the advisory board for the NYU Dentistry Oral Health Center for People with Disabilities, Dr. Michael O'Connor, who will moderate the first panel discussion. Thank you.
Well, thank you, Stacy, very much, and good morning to everybody, and thank you all for being here. It's my pleasure to introduce the distinguished panelists who will discuss funding and access to care for people with disabilities. Our first panelist is Assembly Member David Chu, who's a member of the California State Legislature, where he represents the 17th Assembly District, which encompasses Eastern San Francisco. He also serves as chair of the California Asian Pacific Islander Legislation Caucus. Most recently, he authored a bill in the California State Assembly to expand access to dental care for people with special needs. So welcome, David. Our second speaker is Dr. Alan Finkelstein. Alan is the Chief Executive Officer of Bedford Healthcare Solutions and the former Chief Dental Officer of America Choice United Health Group, ensuring over 3.5 million lives in dental government coverage. He is a longtime proponent of integrated dental and medical care and has lectured at dental and medical schools and conferences on the subject of early childhood caries and the need for Medicare dental integration to achieve the establishment of a quality outcome-based health home. Our third panelist is Dr. Matt Holder. Matt is CEO of Lee Specialty Clinic, which offers a broad range of medical, dental, psychiatric, and general health services for patients with intellectual and developmental disabilities. He is recognized as an international leader in the field of developmental disabilities across the United States and around the world. Our last speaker is Mr. John McIntosh. John is our Associate Dean for Clinical Administration and Revenue Cycle Management at the NYU College of Dentistry, where he's responsible for clinical administration, revenue cycle management, and insurance strategy. John, prior to joining NYU, John held senior positions at major Fortune 500 organizations, including TIAA-CREF, American Express, and Citigroup. We'll start off, the first panelist will be Dr. Chu. Thank you, David.
Good morning, everyone. Thanks for having me, and hello from the West Coast in California. I should start by way of introduction by saying I'm not a dentist, I'm not a doctor. I do play a politician on television out here in California. But listening to your last keynote, Mr. Romano, I was thinking about my own start in politics. I took all my pre-med courses when I was in college. I was on my way to considering a career in healthcare. When between college and graduate school, I worked in New York City, in your town, for Mayor David Dinkins and his mayor's office on health policy. And it was during the 1990s, early 1990s recession, when one of my tasks as a 22-year-old kid was to figure out, with massive budget cuts, who got to get saved during that time period. Were we going to be able to have money for immunizing kids or life-saving drugs for our seniors, or to do preventive care or tertiary care? And that experience, in large part, pushed me to the career I'm in now. I was thinking about the ADA and my own past as a civil rights attorney, and just how fundamental these issues are, not just to dentistry, not just to the field of healthcare, but to a reflection of who we are as a society, our values, our public policy choices, and our fundamental civil rights. I also want to just give a thanks to the NYU College of Dentistry. I had the chance to meet your good dean a number of years ago when the California Dental Association, we actually took a trip to your school because as much as we are proud of our institutions in California, you are doing amazing work at NYU. And we wanted to learn from the best. So with that, I was asked to talk a little bit about sort of my experiences, our experiences out here on the West Coast with regard to some of the issues that you're talking about today. And I'll start by saying, giving a little anecdote about my son. So I have a son who's 4 years old, who is not developmentally disabled, but he has a long way to go in his development. And about a year ago, I took my son to the dentist, and I'm going to say the following preface because I need to as a parent. My wife and I do everything we can to make sure that Lucas brushes his teeth every morning, every night, that he flosses, that we minimize his sugar and his candy intake. But we learned about a year ago that, and my son is literally awake outside the door. Hey, buddy, if you could please just listen. So my son was diagnosed with 6 cavities, which was horrifying. And we have had to do a lot of work to make sure we address those cavities. And it just so happened around that time, I started digging into the data in my city of San Francisco in California around the challenges facing kids and lack of access to dental care. So I represent Eastern San Francisco, about 500,000 constituents. We often say that our neighborhoods are the densest neighborhoods outside of Manhattan. And in my city, I represent San Francisco's Chinatown, which demographically is very similar to New York City's Chinatown. Turns out over half of the kindergartners in my city's Chinatown have experienced tooth decay. This is true not just for Asian immigrant kids, but it's true for Latinx immigrant kids. It's true for African American kids. In our city, 40% of our children have experienced tooth decay by the time they hit kindergarten if they're in our lower income brackets. We all know that low income kids are much more likely to be experiencing, broadly speaking, more health issues than others. But as we also like to say in San Francisco, and I would dare say this is true for New York City, this is true for every major city in this country, it's not acceptable in the most successful cities in the wealthiest nation in the world that this is the case. And as I spoke more to folks from your profession, I was educated not just on the reality for patients who are from low-income backgrounds or immigrant backgrounds, but the intensity of all these experiences. If you are experiencing a developmental disability, you have Down syndrome, you have autism, you have dementia, you have cerebral palsy, the wait lists for care in the state of California are typically over a year long. We have the low reimbursement rates that are experienced by anyone probably wherever you live in the country who is part of this symposium. We know in every part of the country we have, frankly, just too few providers who are also just not trained in how to provide care for these vulnerable populations. So what is it that we need to do? About a year ago, there was a report that came out in California that was called Improving Access to Dental Services for Individuals with Developmental Disabilities. And what it highlighted was the data that reflects everything that I just described. The fact that individuals are far more likely, if you have a developmental disability, to lack access to regular dental care. There are a lot of factors why this is the case in my state. And again, I suspect that these are the same factors true throughout the country. That these are individuals, because they are paying for dental services with state-funded dental insurance, they are challenged in getting access to care. So in California, almost 8 out of 10 individuals with qualifying developmental disabilities are income eligible for dental insurance through our state's Medi-Cal program, which is called Denti-Cal. We know that this is a system that is woefully underfunded, that has dramatically limited access. In California, only 20% of our state's dentists participate in Denti-Cal. And we also know that the traditional approach to Denti-Cal that all of us who are not from these backgrounds experience are not the same experience if you are on Denti-Cal, if you have a developmental disability and you need dental health care. We know that the vast majority of patients who come from backgrounds that are more privileged get to go to private dental offices that may be set up to handle more complicated situations, but that is not the true, and that is not the case when it comes to Denti-Cal recipients. So this is why earlier this year, before coronavirus, I introduced a bill with the California Dental Association to really start to tackle this lack of access to specialized dental care and to support programs that train providers on how to treat these sensitive populations. Now, it turns out NYU and other great dental schools, their clinics, your clinics, are the ones that provide the social safety net for the training, as well as, frankly, the provision of care for California's, for my state's most vulnerable patients, as well as yours. In California at this moment, we have two great schools, UCSF and UCLA, whose dental schools both are providing care through special needs clinics. But at those clinics, they're backlogged with typically a minimum year-long wait for treatment. In many instances, the wait list is 2 years or more. And as I said before, you combine very low reimbursement rates for treatment, plus the fact that treating these populations require additional time, additional skill, it compounds into a very challenging situation. So the bill that I introduced, AB 2146, would have ensured that our state's special needs dental clinics have access to federal matching dollars. It would have authorized and directed these these university dental schools to enter into what are known as intergovernmental transfer agreements with our state's Department of Healthcare, along with Federal Center for Medicare and Medicaid Services, to fund increased Medi-Cal dental care provided in the clinics. Or put another way, we figured out a way to draw down more state funds by matching with federal governmental authorities in order to fund our public schools, universities, when it comes to dental care in this area. This is incredibly important for obvious reasons because the system is underfunded. And during this time period of pandemic, when our state is grappling with a $54 billion budget deficit, even more crucial than ever. Now, all this being said, the punchline to this, the global pandemic took over our legislative session. Like most state legislators in the country, we had to shut down for a period of time. I had colleagues that were diagnosed with COVID, so we were not able to move forward with this bill. But that being said, we will certainly be moving it forward in the coming months. And our hope is that, like New York, like other states represented here, we're hoping that California can hopefully provide and ensure timely, thorough, affordable dental care for all. So appreciate being on. Look forward to the discussion.
Thank you very much, David. And how we're going to manage the panels is that each of the panelists will make some opening remarks, and then we'll be open for questions through the audience that Stacy will relay to each of the panelists as we go forward. So our next speaker will be John McIntosh, Clinical Administration Dean here at NYU. John? David, you should stay on if you can. Thank you.
Thank you and good morning and welcome to all. As I was introduced by Dean O'Connor, my name is John McIntosh, the Associate Dean for Clinical Administration and Revenue Cycle here at NYU College of Dentistry. As we all know, oral health is essential to the general health and well-being of individuals, yet significant oral health disparities persist in the US population. This affects both oral health access and effective dental health care. Many individuals who have disabilities or complex health conditions do not have adequate access to comprehensive oral health care. We here at NYU recognize that. We currently see roughly about 300,000 patient visits per year. However, prior to the decision to build out our oral health center for people with disabilities, we were seeing roughly about 25 to 3,000 patient visits per year. This is roughly about 1% of our total patient visits. As we're all aware, the decision was made by the Dean Charles Bertolami, to fund and build out a state-of-the-art oral health center for people with disabilities. Once the center was built, our goal was for the center was to increase our patient visits to around 8,000 patient visits per year. However, early in 2020, before the pandemic, we were well on the road to be hitting close to 10,000 plus patient visits. So we were definitely moving forward in the right direction. The Oral Health Center for people with disabilities obviously was closed during the pandemic and reopened in August. We are currently treating about 20 to 25 patient visits per day for the last month, which tells us that we're again on track. Although we have some limitations, we're moving forward in the right direction. One of the challenges for our process is financial barriers to dental care, especially to this population. These barriers obviously have negative effect with respect to dental visit and oral health outcomes. To address the issue of affordability, NYU Dentistry continues to maintain a well-discounted fee structure for all of our patients. We provide a rich array of payment options, which include Medicaid, Medicaid managed care, private insurance, third-party financing as Care Credit and Lending Club. We also have direct pay, which obviously would be cash and all major credit cards to support that process. When we look across the spectrum of patients within that population, 70% of our visit in the center is either Medicaid or Medicaid managed care. Our Medicaid reimbursement rate that we are currently getting from the state of New York is about $158.55. However, the yield from that visit is roughly about $100. The same visit in a hospital is about $800. It's important to note that the hospital have a long wait time than we do have. So their wait time is about 6 to 12 months. And I think the prior speaker indicated that in the state of California, within his district, it's a much longer wait time. Although our reimbursement rates are low as we are getting back from the state, it is the goal of our leadership to ensure that this population is not, there are no barriers, financial barriers that will stop them. So this population have a dental home at NYU Dentistry, and that is very important for us to highlight. There are members of the executive team led by Michael O'Connor, Erin Brent, and Gabriela Gonzalez, who have recently met with Greg Allen, the director of the Division of Program Development and Management, and he is responsible for Medicaid services and planning policy. And the goal there was to work with him to be able to encourage an enhanced rate for this within the state of New York and obviously for NYU dentistry. I would like to thank everyone for taking part and listening to this presentation. Thank you very much.
Thank you, John, very much. Our next panelist is our good friend, very, very good friend, Matt Holder. Matt?
All right, thank you so much. I'm going to share my screen here and bring up some slides. Let's see if I can do this. Uh-oh, screen sharing doesn't seem to be working, folks. Well, let's see if it goes. Is it working now?
You're good, you're good.
All right, great, great, great. Okay, so thank you so much. It's just a wonderful, wonderful start to the day. My name is Dr. Matthew Holder. I'm a physician, not a dentist, but I've spent the last 18 years in the field of developmental disabilities. I am in Louisville, Kentucky, and we have a clinic called the Lee Specialty Clinic there that focuses entirely on people with intellectual and developmental disabilities. We focus primarily on adults because that's where the need primarily is. However, just so you know, and I'll describe the clinic in a little bit, but we started off as a dental clinic. And so, you know, what I'll describe to you is sort of the second phase of the Lee Specialty Clinic. But originally, we started as a dental clinic because that was undoubtedly where the greatest need was. We're an interdisciplinary clinic. We're into teaching. We're into research. And if you would like to learn more about the clinic, here's the website, leespecialtyclinic.com. So our core services, we offer medical care, dental care, psychiatric, behavioral, therapeutic, PT/OT, and speech, a whole bunch of specialties like ophthalmology, audiology, podiatry, gynecology, a whole bunch of things, crisis intervention. And we also have an AEGD dental residency. I think it's the only one in the country that has 100% patient base of patients who have IDD. And I'm proud to say we're part of the NYU family because of that. But I think one of the important things here is that we're not just a bunch of these separate disciplines that happen to be in one place. We operate interdisciplinarily, which means that, you know, our dentists and our psychiatrists are talking to our speech therapists, to our physicians, and our care gets just exponentially better because we do that. Now, here's the state of Kentucky, and that little dot there that says LSC is where we are geographically located. And the little red areas are the counties from which we pull our patients. And the reason why I just want to show this is just geographically to show you how far people drive each direction to get care from our clinic. And you sort of have to ask yourself the question, in a state with 4 million people that has 2 dental schools, why does somebody have to drive 4 hours each direction to get their dental care somewhere? Well, the answer is pretty obvious that, you know, they can't find a dentist between them and us that will take them as a patient. And whether that's from lack of training or, as Neil Romano was talking about, lack of accessibility or any myriad of factors, it is a reality. Now, our funding comes from the state of Kentucky. It is primarily through the Cabinet for Health and Family Services, the Department of Developmental Disabilities and Behavioral Health, and the Center for Medicaid and Medicare Services. And that allows us to do things that most private practice clinicians would not be able to do. We do bill Medicaid, Medicare, and private insurances, and I'll tell you that probably 95% of our patients are Medicaid and Medicare. And if we had to subsist on that alone, we would go bankrupt in probably a month because, quite frankly, that probably only accounts for about 20% of what it costs to actually run our clinic. So we thank our state every day for being willing to provide that backstop. I'm just going to ask a little philosophical question for you just by showing you a couple of pie graphs. The first one on the left here is the pie graph of the population of people who don't have intellectual and developmental disabilities, so we'll just call them neurotypical, and people who do. Now, if you were going to design a dental clinic or a medical system or a medical clinic of any kind, who would you design it for? The big blue piece of the pie or the little red piece of the pie? I mean, very simply, you're going to design it for the blue piece of the pie because that's who most people are. And so it's no wonder that our little red piece of the pie there, right there, is kind of ignored in that system. But philosophically, I want to take you to, okay, well, we've recognized that there's a problem. People with IDD are not being well served, but there's another pie that you need to be aware of, and that is that the vast majority of people with IDD are in this mild category. And, but there's a good chunk there that is in a moderate, severe, profound, meaning that they are significantly more complex from a medical, a dental, and a behavioral standpoint. The problem is that if we start talking about designing a system, designing an office or whatever for people with IDD, we have to make sure we don't make the same mistake that we made over here with the general population in the blue pie, by designing it only for the red pie. We have to make sure that we're not leaving anybody behind. We really need to design what we're doing for the little purple sliver and the little green sliver. And if we can do that, if we can take care of those individuals, then everything else is going to be a piece of cake. Those individuals, as I'm talking about here, and this is just from a medical standpoint, is just to show that as you get deeper into the spectrum of intellectual disability, we have to remember intellectual disability is caused by a neurodevelopmental disorder. And the stronger that neurodevelopmental disorder is, the more you impact the brain and the intellectual function of the brain, the more you're going to impact the other things that the brain can do, or what happens when the brain can't do those things. So just showing you here, this is data from our clinic, but it just shows that as you go deeper into the IDD spectrum, what you find is more seizure disorders, more autism, more neuromotor disorders, more psychiatric disorders. And I can guarantee you that not only do we find more, but they're also more severe, which makes these individuals eminently more complex. So looking at intellectual disability a different way, here's a little pyramid, just to show you again, 85% mild, 10-15% moderate, severe, and profound. Now, if you look at the CDC numbers, and just do a little math, what you'll find is that the average person with IDD on Medicaid costs 3.6 times as much as somebody who does not have intellectual disability. Now, what we know is that people who are on the mild end of the spectrum tend to look a lot like people who just fall into the general, I'm going to use air quotes here, disability category. And so people with general disabilities often cost roughly about twice as much as somebody who does not have disabilities. But algebraically here, for breaking this down, the CDC study, what you find is if that group of people costs double, and they approach what the rest of the disability community looks like, this group up here at the top is extraordinarily expensive. We're talking 12 times the cost, okay? So it's a very small group of people, but it's a very, very big cost. And in my mind, this is the basis of the financial argument for focusing on people with IDD, because even a little bit of savings here, doing the right thing, magnifies an awful lot. One of the reasons why we have this giant explosion of cost has to do with deinstitutionalization. So if you think about it just from a purely economic standpoint, you know, I'm a big fan of deinstitutionalization. I love the fact that we're community integrating, but one thing that was a positive to institutionalization was what we call in business economies of scale. You've got all the doctors there in one place. They're all relatively expert in this patient population, and they know kind of what they're doing. The minute you take that away, then you push everybody out in the community, and now who are they going to? Well, if they can find a doctor who will take care of them, or a dentist, that person probably doesn't have a lot of training. And what we end up seeing is in this group of people, a lot more medications than they should have, a lot more emergency room visits. And we're talking 2 to 3 times the emergency room visits. We're talking probably 14 times the medication costs, lots of inpatient psych, lots of ICU and hospital visits, right? So this comes as a result of that. Now, why is that? Psychologically, there's a thing called the Dunning-Kruger effect, which I absolutely love. And I would spend a lot of time on it, but basically what it just says is that when you learn a little bit about something, you think you know a lot more than you actually do. And that is a very dangerous place to be. So if we take our average dentist or our average physician and we give them 30 minutes of training and say, now go out and and treat people with IDD, well, the decisions that they're going to make are probably not going to be the best, especially when we're talking about this complex group of people. And what that results in is what we call diagnostic overshadowing, which is essentially a fancy term for misdiagnosis. I've got a couple of medical examples here, but I'll walk you through a dental example of diagnostic overshadowing. So we start off with a patient who's having some kind of behavior. All right, now I'll give you the punchline right now. It's a behavior that is due to a dental abscess, and this person cannot communicate that, okay? Now, the way that that's going to be recognized is by a caregiver or a family member or something along those lines. It might even be recognized by a dentist, but more than likely, at this point, they're not going to the dentist. This is a behavior complaint. So they go to the medical system. What happens? The psychiatrist looks at it and goes, ooh, behavior complaint, antipsychotic, that'll take care of it. Or the primary care doctor, antipsychotic, benzodiazepine. We medicate the behavior. What happens? The behavior goes away, because guess what happens when you give behavior medications to somebody? That's what they do. They take the medications away. The problem is that we never actually treated the real problem. So the problem gets worse. The dental abscess gets worse. Now you have 2 dental abscesses. Now you have 14 dental abscesses. And we've seen patients like this, okay, many times actually. So the behaviors increase again. And now what happens? We start this cycle all over again. And it might be, we might go through this cycle 2 or 3 more times before we actually figure out, wow, it is a dental abscess. And unfortunately, that leads to a lot of delay in care. And of course, bad outcomes as well. The person is suffering the entire time. So just to talk about antipsychotics for a second, I have to ask ourselves, how much of the problem are we ourselves causing? Imagine somebody who's now had this dental abscess, but now they're on antipsychotics. Maybe they're on 2, maybe they're on 3. And by the time we discover that it was a dental abscess to begin with, nobody makes the connection that all those antipsychotics they're on now are because of the dental issue. So those things are going to continue forever. We diagnose psychosis in this population 6.5 times more than the regular population. And I can tell you for a fact, based on my patient population, there is no way that 1 out of every 9 people with IDD is psychotic, but we prescribe medications like that. Unfortunately, these medications have a lot of long-term side effects: tardive dyskinesia, dysphagia, swallowing problems, GERD, gastroesophageal reflux. Okay, these are things, by the way, that a dentist can pick up on. Okay, so right here in the middle of this cycle, if a dentist is looking at things, he might be able to do something, he or she might be able to do something and raise a flag and stop the rest of this cycle. The problem is when you start to have these things go on for very long, you set up somebody for pneumonia. They can't swallow very well. They're starting to regurgitate their stomach contents. And guess what that means? Aspiration pneumonia. What kills people with IDD more than anything else? Aspiration pneumonia. 1 out of every 4 people with IDD are going to die of some kind of pneumonia-related illness. I guess I won't say it's all aspiration pneumonia, but some kind of lung-related, pneumonia-related illness. That is a massive killer of this population. Again, we have this delayed care cycle, and they end up in the hospital. Okay, the number 1 thing that happens to people with IDD when they're in the hospital, the number 1 thing, oh, and also the number 4 thing, is they're on a ventilator. That's the number 1 thing. The number 1 thing for everybody else is getting a C-section or something like that, okay? So what that means is we're getting to the actual problem way too late. But this is something that a dentist could actually intervene on. So just, if I don't know if this video is going to come through, but you're going to see little fasciculations of the tongue here. A very early sign that this person is starting to experience those side effects of antipsychotics, okay? And so our dentist caught this, and we had a big conversation with our psychiatrist, managed to take the person off the drugs, right? Now they are not a setup for aspiration pneumonia again. And there's a whole lot of other medical things that dentists can intervene on, that they can be a part of. This list right here are just some things, again, that our dentists have caught over the years, all right? So it's not just, let's get out of the mouth, and let's put the mouth back in the body. Let's start talking about, physicians and dentists, everybody working together, because, You know, it's not just drill and fill. There's a lot of things here that dentists can do that make a big difference cost-wise, and I think that's very important. One other thing I'm going to talk about is operating room. So some people think that an operating room is synonymous with this population, and I'll tell you that the national average of sending somebody to the operating room with this population is about 25 to 35%. Now, in our clinic, it's 1.8%. Now, how is it possible that our clinic that specializes in some of the most difficult and complex cases can have a 1.8% referral to the operating room? Well, it's because we focus on this, okay? And out in the community, you know, you've got other dentists. The minute somebody just raises a finger, says, I don't know if I'm really into this, or heck, sometimes they just come with the diagnosis of an intellectual disability and say, oh, that's how we do it. We take them to the hospital. The point is here in our clinic, just running the numbers, if you look at a 30% rate of going to the operating room, we would be spending about $1.6 million more than our clinic is right now, about 1.5. The point is here is that when just in looking at operating room costs, not in all the theoretical medical costs, but just one aspect, my dental program probably costs less than $1 million altogether. So we're saving $1.5 million a year just with this one factor. It pays for itself. It's practically free dentistry, and it pays for some other stuff too. So when we talk about funding, I'm going to leave with just this this little summary of what I see. One of the most important things to note in this population is that you will find clinics like mine around. There are some in New York, there are some in California. Because we don't have a good funding mechanism for this type of program, for these kinds of clinics, every program that you see is contorted in some way. They're contorted in some way because either they have to go out and fundraise a whole bunch of money, which means that they have to spend a whole bunch of off-mission time doing stuff, or you know, if they're accepting a whole bunch of Medicaid patients, well, they have to figure out a way to make up that difference. So what's that going to look like? In my case, we're state funded, and while that's actually a great thing for us, it's not easy to reproduce because you have to have a lot of in-state political power in order to make that happen. Another thing that we talked about are FQHCs, and FQHCs can be a fairly decent way of getting dollars, but they're not designed for the IDD population. So you still end up sort of shortchanging the more complex end of the spectrum. So we're working on a new method of funding care for people with intellectual and developmental disabilities. Here are some of the hallmarks that I think just need to be followed. First, I really believe in this interdisciplinary aspect of things. I'm tired of you know, dentists being afraid, even my own dentists or the dental students that come through, being afraid to talk to a physician because they think, you know, they won't be respected or something. Forget that. You know, we need to have that. We need to make sure that these things are designed for even the most complex people who have IDD. This needs to be specialty driven, but it needs to be in a way that is teaching generalists. So I know in dentistry, there's always they shy away from a lot of specialties, but you can't teach the generalist something unless you have somebody specializing in it. Otherwise, you just sort of have a generalist teaching a generalist, and you know, you can only go so deep with that. I think the big key to everything here is we have to tie it to the big picture. We've got to tie it to the overall medical spend. And I can tell you in my state, it's absolutely crazy trying to figure out what it is. You know, I know that we're saving millions of dollars of Medicaid spend, but we have this really interesting phenomenon where Medicaid keeps cutting and keeps cutting and keeps cutting. So nobody wants to take Medicaid patients. So then what does that do? Well, it delays care and it sends everybody to the hospital where guess what? Well, 60% of this population is dual eligible. So now they go to the hospital. Well, who pays for all the hospital bills? Medicare. So suddenly you're just cost shifting. You're cost shifting from one place to the other. And the people in the middle of that are suffering. So what I wanted to say is we need to take a very, very broad view of what we're spending, and we need to include dental care into that calculation. I believe that we need to look at, and this would lead us to sort of a value-based conversation. I know Dr. Finkelstein is going to talk about it a little bit, so I won't spend much time on it. But my last point is that we have to be highly ethical, and we have to build in the ethics of taking care of this population. It is so easy because this population typically does not have an easy time advocating for itself. It's very easy, and I've seen it over and over again, to constantly decrease the quality of care. When we built our clinic, we made sure that there could be no financial incentive whatsoever for us to decrease our quality of care and increase our profit or increase our revenue. We made sure of that. Anything that we do, you know, when we talk about providing online care to patients with intellectual and developmental disabilities, we have to make sure that we don't just start doing that because, you know, it might be a little lower quality and we start thinking, well, a little lower quality is okay. It's not. For this population, this, you know, just saying a little lower quality, well, that gets us to where we are right now. So I just want to make sure that we build that in. And I will stop talking at this point. Thank you so much. If you have any questions, here's my email address. I'd be glad to speak with anybody about this or any other aspect of caring for people with IDD. Thank you so much.
Thank you, Matt, very much. Terrific. I really appreciate that. And I think that we may get some questions from the audience in a couple of minutes. Our final panelist on this topic is a very, very dear friend, Dr. Alan Finkelstein. And as I gave you his background already, but I do want to go out of my way to let the audience know how committed he is to this program of ours here at NYU. He's been a very, very special supporter of us in many, many different ways. I just want to acknowledge that publicly, how much he's provided to us in terms of his background, his intelligence, and even his personal resources to make our center a little bit better than it is. So thank you, Alan. And I'll turn it over to Alan now.
Thank you. I hope to, I'm hoping the screen comes up. Share my PowerPoint. Is it up?
Yeah, it's good. It's good.
Okay. Well, it pays to have higher education, I guess. Thank you very much for inviting me to be on the panel. Matt, and you're right, we do want to talk a little bit about kind of a disruptive innovation methodology for reimbursement, and that centers around value-based. So I would like to thank again Dr. Bertolami for allowing me to be part of the early planning of this incredible facility, and I invite everybody. We're very proud of this wonderful treatment center and what it truly is and what we'll talk about. To me, it's a Special Smiles Health Home. So I'd like to start with a statement. Americans with developmental disabilities, whether physical or intellectual, encountered nearly insurmountable obstacles in securing dental treatment. Because of the disabilities, these individuals are simply unable to tolerate and cooperate with dental diagnostic and treatment experience, leading to great delays in receiving care. Providing such care falls directly within the mission of New York University College of Dentistry. These limitations usually preclude care in typical dental offices, which in turn leads to a major delay in receiving care. I can tell you in my past life, trying to build networks that caters to this special population is nearly impossible. We cannot live with combining this with children, healthy children with caries, and the backlog that we have at hospitals, and above all, the backlog in ambulatory surgical centers has to be met with a different approach. And that's what the plan behind our center at NYU is all about. So the special needs dental health care for people with disabilities. Basically what we're talking about is the dental home, providing the dental home for this special population, and combining it with a medical home to form a Special Smiles Health Center home. And if you notice, the denominator, the common denominator in all of this is behavioral health. And without that, we are just practicing repair dentistry. So by behavioral health and integrating, as Matt pointed out, in the great state of Kentucky, that we have to have a methodology to combine all aspects under one roof. And then we have to develop the true, shall we say, spirit of this by taking the dental home, the medical home, the behavioral health home, and build around it the reimbursement model. Right now, we are built on disease, followed by disease, followed by disease. And that's how dentists make a living. My practice is based on implant dentistry. I get rewarded for placing an implant, which is the admission of the ultimate failure. The tooth is lost. But yet I get rewarded handsomely to do a fancy implant. And now what I'm seeing, and hopefully this, so we say, siege will stop, where implantology is taking over the preventive angle. And we have to get the schools back to pushing prevention. And the only way that's going to happen is by those magic boxes on either side, is starting to reward for reimbursement for prevention. Prevention of disease, early diagnostic, and prevention is the only way that we're going to be able to get to a bottom line that is outcome based. So we must include all aspects in integrated care. So the characteristics of the Special Smiles Health Home: one, we want to shift from pay for procedure to pay for outcomes, measured based on an individual oral health status. It's what we accomplish with that individual patient that we should be rewarded for, okay? In a population-based setting, a community-based setting, but how we achieve health and maintain that health through life is the way the reward system should be set up. Financial accountability for oral health status of the special needs population under care. So when we start with a amount of this oral disease and convert it to baseline health, we must monitor that on visits, return visits, and see that we're maintaining that health. And that's where we build the reward in, not by the number of teeth that need restoration, but what did we maintain after we've established that health? Dentists practicing in interprofessional teams within integrated health, we no longer look at the individual. That individual dentist provider now has to be combined with a healthcare team, and that's behavioral health. That would be the primary care physician. That would be in the facility that we have at NYU, working in sensory health, really getting down to what the patient's needs are, establishing a treatment plan, not based on a benefit package, but based on the individual's need. The high value for cost savings and health producing prevention, health promotion, disease management, and conventional treatment will lead to better outcomes and cost savings. And it's time for insurance companies to start to see that. Yes, we're blessed in dentistry not to believe in diagnostic codes. We pay procedure codes, and that's what we live by. When we try to get a dentist to join our networks, what is the driving factor? They look at certain codes, what the reimbursement is. Nowhere do they even look, why shouldn't I be receiving higher fees for prevention versus restorative? That is the brain and the, shall I say, mindset that we have to develop. So in rapidly changing healthcare landscape, payers are asking providers to shift from volume-based or fee-for-service to a value-based reimbursement structure with a population health approach. This evolution toward value-based reimbursement benefits the patient, the healthcare provider, and the payer. And above all, what we have to do is making the move to value-based will require transforming the traditional siloed care model into a network care model, both for increased coordination, ability to scale effective interventions with the patient, a significant increase in the need to acquire, aggregate, and analyze the data across healthcare networks, integrate financial and clinical platforms for a common view of patient across all settings and over time, recognizing institutional structure. to accommodate value-based payments based on benefit package, utilizing risk assessments modified by medical necessity. Therefore, we have been practicing in dentistry too long, again, based on what is covered. What is covered is to restore that patient back to baseline maintainable health. And how we do that over the ages, we have to invest in children, bring them in especially in our special needs category, is age these patients, starting with our children, into a state of health and reward the provider for such. So we no longer can go back to the 1940s when a commercial toothpaste company said, see your dentist twice a year, brush 3 times a day, and cut down on sweets. That's not anything to do with reality. What we have to see your dentist is based on risk assessment. And when we have a population of special needs, twice a year is totally inadequate to see a child. Our insurers have to recognize established benefit packages based on need and outcome, not based on a commercial toothpaste. Dental providers' engagement with common goals and incentive structures that support these goals will provide the outcome metrics that we need to analyze. So dental healthcare is in a transformational period. Dental payment models will be shifting from fee-for-service to new purchasing systems in which providers are reimbursed on outcomes for treatment for the individuals that they treat. The Special Smiles Health Home includes special needs quality goals that result in better outcomes or reducing treatment costs in an established integrated health home. To accomplish this, a state-of-art interprofessional oral health care facility such as we have at New York University must be the true safety net that is needed in all communities. So if they have to travel 4 hours to Matt's facility, we must put 4 hours or 3 hours or 2 hours and make that access to care based on true access, because it is difficult and we can't have backlogs that we have a year to 2 is unacceptable. We want the quicker and the earlier we see and intervene for this disease population in special needs, the better our results will be. So basically, again, I extend an invitation when you're in New York, when you're free to travel again, and come and visit what's on the 8th floor. And I can only make one hope and one wish that all communities have a New York University that they can refer their special needs population to. Thank you very much.
Thank you, Alan, very much for your presentation. Very, very interesting. The value-based program is something we're all striving for. We have about 5 or 6 minutes left for questioning. There are a couple of questions that I know Dr. Stacy Ripke has been gathering for us. Before I open it up, I wanted to know if any of the panelists had any other remarks they would like to make, or if they have any questions for their colleagues on the panel. If not, I have one or two, and I was going to go to David, if I may. David, you mentioned that right now, the waiting list for a person with disabilities at some of our peer institutions might take as long as a year to be seen. Do you know what, in quotes, the rest of the population has to wait? What is the normal wait for somebody who is not falling into this category as a disability patient?
Well, I should say in many instances it's actually more than a year. We've seen a few years, and our entire California dental Denti-Cal population is woefully underserved. Like, this is a broad problem, which I'm sure is the case around the country. But this particular subpopulation is even more impacted. And I was really intrigued, I think, by Matt Holder's information about just how expensive this gets with this particular population. This is a challenge, not just with access, but just from a budget standpoint. It's a very, very challenging situation.
Our experience when we were planning out the center here, we visited many other community health centers who were treating this population. And the way to New York, as John said earlier, was anywhere from 6 to 12 months. And then what would happen is that the patient would go to the community health center and be told they couldn't be treated, and then was referred to a hospital. And the hospital had another 6 to 12 months. So minimally, a patient would take it, just like in California, as you're suggesting, anywhere from a year to 2 to be seen. And by that time, as we all know, going back to the prevention argument, the situation, and Matt and Alan hit it beautifully, the situation just gets worse and worse and worse. And the cost goes up and up and up. So I think that's something we all have to think about. John, if I may call upon you, my dear friend, you're familiar with our center here. What is the average wait for us to see a patient who has a disability?
Michael, currently we're actually running a little over a week. So within a week, we were able to see patients. They were able to come in and be treated.
Yeah. So anyone out there who has patients that want to be seen, just get in touch with us and we'll provide you with the information. That's why we built the center. Alan or Matt, any questions? David? If not, I'll go to the general audience and ask Dr. Ripke if she can repeat a question that might have come in through her, and we'll see who on the panel might be able to answer it. Thank you.
Yes, we have a question from colleagues joining us today from Tufts University School of Dental Medicine, where they see approximately 6,500 patients with disabilities per year in a joint Massachusetts State Tufts collaboration to provide care to this population. They note that the COVID-19 pandemic has pointed to clear gaps, how to upgrade the physical plant, obtain PPE, and so much more. Given this, they ask, how do we position oral health and oral health care for this population so that the state prioritizes this much needed care?
Any of the panelists want to respond to that?
Yeah, Michael, it's Alan. I'll be happy to. One of the things, we have to get some relief, especially for Medicaid providers in educational facilities, even more so. The relief has to come with PPE help. We have to get the American Dental Association to create a unique code in times of emergency, which is being missed. You're being advised to use a code that is used for payment for FQHCs. So the first thing I would say is putting some money, and we have to have more flexibility in our system. And I challenge the ADA to meet that in times of emergency. Business can't be as usual. So that would be the first relief. And the other thing, and I'm gonna really create a hornet's nest with this, we have to have oversight. There's been low utilization for approximately 3 months. Premiums are being paid. It is time to establish relief to people, providers on Medicaid. The dollars are there if someone would take a deep breath and look at it.
Thank you, Alan. We're almost out of time. I do want to mention that one of the challenges that we have had when John was nice enough to mention that Erin Brent and Gabriela Gonzalez and I went to meet with the State Department of Health leadership. One of the issues that they want people like us to provide is data. There's a dearth of data about the population and the cost associated with providing at least oral health care for people with disabilities. I know we tried very, very hard to work with other institutions to find out information so we can provide it to the state. And thus far, we haven't been able to do that. So we were building up our own health services database to go up back to the state. We were supposed to go back to in April with information to see if we can get an enhanced reimbursement model. They're open to it, but we have to prove it in order to get the money. So if there's other folks on attending today's program, we would love to hear from you, because I think the more we can coalesce as a group and serve in that advocacy position, the better. I think we're out of time. I'm getting one of my colleagues letting me know we're out of time, and that's wonderful. And I want to, first of all, thank all the panelists for their insights and their professionalism and all of the support of today's program. So thank you all very, very much. Thank you. Okay. It is now my pleasure to introduce Dr. Ron Kaczynski, who will moderate the second panel, the family provider relationship. And before I turn it over to Ron, I just want to say that I've worked with Ron now for the last year and a half. And all I can tell you is that his passion and his love in treating patients with disabilities is absolutely amazing and inspiring. So Ron, I'll turn it over to you.
Thank you, Michael, for your very warm introduction. I appreciate it tremendously. I am humbled to be the clinical director of this facility, and I am so grateful to be the clinical director. It's with great pleasure that I get to introduce our panelists for today's second panel. Joanne Simon, our New York State Assembly member, will be speaking, and Costello, the executive director of the B. Thomas Golisano Foundation, Karen Raposa, clinical education manager of the Hugh Freedy Corporation, and Barbie Vartanian, the executive director of Project Accessible Oral Health at the Viscardi Center. And I know we speak about our home health, our healthcare workers as being heroes. I have to say that my heroes lately have been the parents and the caretakers of people with disabilities during this pandemic. And the two people on our panel have children with disabilities. Both Karen and Barbie have children on the ASD spectrum. And they are true heroes to me as parents have been fraught with very difficult times during the pandemic. And the first speaker today will be Barbie. And Barbie is going to speak about some experiences that COVID-19 has crippled some of the people in not only in the community, but in her own family. So without further ado, Barbie, you're on.
Great, thank you, Ron, and thank you, NYU, for having me and having this perspective as a panel today. So, like Ron mentioned, I'm the executive director of Project Accessible Oral Health, which is a global public-private partnership dedicated to improving access to oral health care around the world and for the more than 57 million individuals with disabilities. And later today, you're going to hear from two of our three founders, Steve Cass, John Kemp, and then our third being Mark Wolf, who's now the dean at Penn Dental Medicine. So, and I'm also honored to be on the advisory board of the NYU Dentistry Oral Health Center for People with Disabilities. So that's a little bit about me professionally, but I am also the mother of a 12-year-old nonverbal son with autism, and this is my beautiful son, Sam, who may run in the picture at any time, we'll see. But I don't profess to know the challenges from the perspective of an individual with a disability, but I'm fully aware of the challenges as a parent and a caregiver. You know, and I see firsthand how the world treats my son, and I see that his needs are often not prioritized in everything from education to healthcare. And this pandemic has further exacerbated those disparities facing individuals with special needs. For my son, COVID has meant no school, no support services like OT or speech, and no horse therapy, no Special Olympics activities. And it's also meant something so secondary to you and I, the inability to access preferred foods. So as people were loading their shopping carts with foods they probably didn't even like, you know, Sam had to do without a meal that he had come to know every day and had come to count on. So as Sam tried to navigate this new normal, his behaviors went through the roof, and he became extremely aggressive. So much so that he broke my ribs because we couldn't find his flip-flops one day when we were going to the beach. So I share these stories because it's important to understand what you or I may find difficult or inconvenient. Just magnify that by 1,000% for those with special needs. Next slide. So the headlines, all over the place you see, you know, firsthand the challenges that individuals with special needs and their caregivers are faced with during COVID. And it's further separated the disability community from the neurotypical one. The headlines are filled with stories of discrimination towards the disabled community, from the prioritization of the pending COVID vaccine to the non-existent representation in Hollywood. And I only bring that up because if there were more roles, there would definitely be more awareness. And then the provision of education for individuals with special needs was another of the most affected area during this pandemic. They were never considered with the immediate shutdowns, and they definitely weren't considered in the return to school. School districts often communicated what was going to happen for the gen ed population with zero mention of those in a special education program. Next slide. So this recent slide is absolutely heartbreaking. This is about a mother who has a son with autism, and his behaviors were alarming to her, so much so that she called the police for support, thinking that they could help calm him and get him back to a place where, you know, everyone felt safe. And when the police officer arrived on the scene, obviously probably feeling threatened, he opened fire on the child, and the mom, obviously horrified, again thinking that she called for help, and you know, this officer probably thinking that this child was going to be a detriment to him, possibly himself or the family. You know, this is something that that took place, and you know, it's so important to realize that families are struggling so tremendously right now. And the individuals themselves are beyond loss, they're confused, they're scared, and society continues to overlook them and their needs, and unfortunately leads to situations like this. So underestimated. I'm often asked how I would describe the special needs population, and my word is simply underestimated. I think we as a society assume that these individuals can't do what neurotypicals can, and that's simply not the case. They understand so much more than you can imagine, and they want to be included in every aspect of their lives. And believe it or not, that even includes the dental visit. So this picture here is a few weeks ago. I took my son to his first dental visit since we moved to New Jersey. And let me tell you, I was extremely nervous. And because of COVID, I was even more nervous because Sam has been struggling so significantly. And normally I would take his behavioral therapist, maybe even an occupational therapist, you know, a cousin, you know, anyone on his team that I thought would help, you know, us facilitate a successful visit, you know. And as you can see here, he does have his iPad and he's got his jump rope, and thankfully, you know, things went really well, thanks to Dr. Christina Carter, who's also an NYU grad, who I met through Dr. Perlman. And, you know, she was absolutely amazing, and Sam did tremendously well. And once again, I found myself, you know, thinking back to that word that I use all the time, underestimated for this population. And I did that with Sam that day. And, you know, once again, he exceeded my expectations. And, you know, and it didn't take any more on the part of Christina, as the provider, is just how she approached Sam and what her attitude was like as she treated Sam. So next slide. So this is another story about a wonderful young man named Terrence, also autistic, and his journey, you know, in the beginning in terms of oral health was actually relatively successful. His family had been seeing the same practitioner for very many years, and unfortunately he retired. And the practice gave his mom, Tina, a referral. And she was very nervous, but obviously she knew she needed to continue Terrence's oral health plan. So she called, she made the appointment, she got there. And when she got there, she told the staff all about Terrence and you know, some of his challenges and things like that. And unfortunately, they chose not to listen, and it was a disaster. And so it was more than 2 years of an exhaustive search. And actually, Terrence's mom, Tina, stumbled on the Lee Specialty Clinic. And, you know, his life was changed. Terrence smiles all of the time. And when I asked, you know, Tina what she thought it took, and it really just boiled down to attitude. You know, her hopes are that the, you know, the profession embraces this population. So again, you know, it's the mindset that helps one see and recognize these opportunities. And again, it goes back to attitude, the attitude of the parent as it relates to the importance of dental care, and then basic maternal attitudes and anxiety levels of the parent also affects the child and how that visit may go. And then it's also the attitude of the provider and how they view the patient. Individuals with disabilities have a keen awareness of how you perceive them and your comfort level around them. So we need to see beyond the disability. So consider how overwhelming a medical and dental visit is to an individual with special needs, and find a way to improve that experience. So here's a quote by Dr. Lyons. Clinical dental treatment is the most exacting and demanding medical procedure that a person with ID or DD undergoes on a regular basis throughout their lifespan. Next slide. So the role of a health professional in addressing bias, and I think these are some really, really important points. You know, a health professional has a lot of influence over the lives of people with disabilities. So you as a provider control access to medical and dental care. And in many situations, you even control the opportunity to make decisions and form and maintain relationships. You influence research questions, funding methods. Your research drives policy. Your words, actions, and leadership matter. And by addressing your own bias, you have a tremendous opportunity to improve the quality of life for people with disabilities. Next slide. So champions are born. Champions are not born, they're made. So how do you become a champion for this population? Well, you can advocate. We must create a groundswell for inclusion, for health equity, for accessibility, both provider and practice. And I love what you know, President Hamilton said earlier. It should not be extraordinary that NYU has this tremendous center. It should be ordinary. And then we have to advocate for reimbursement change. Providers are dropping out of Medicaid like never before due to COVID. So now more than ever, this community needs champions. And I'll leave you with this last slide by Mother Teresa. Let no one ever come to you without leaving better and happier, and I added healthier. Thank you so much.
Thank you, Barbie. I think. Thank you so much. Without further ado, I would like to introduce Karen Raposa. Karen is the Clinical Education Manager for the Hugh Freedy Corporation and also a mother of a child on the ASD spectrum. Karen.
Thank you so much, Ron, and thank you to NYU for this opportunity to speak as a parent of a young man who just turned 21 years old, and you can see him on your screen. That's my son, Tommy, and my husband and I, but also to be a voice for him, I hope, today. And my story is similar to Barbie's, yet slightly different. While my son is severely impaired by autism and has a lot of the behaviors that Barbie had mentioned, Matt talked about this category of individuals who are, the cost for their care is about 12% higher compared to a typical or neurotypical individual. And my son does fall in that category. He has a lot of self-injurious behaviors because he can't speak very well. Most of the time, you would not understand what he's trying to say, although as his mom, I do understand what he's trying to say very often when others don't. So part of what has had to help him through this challenge is that he has to wear splints on his arms most of the time, and he will even ask for those splints because he's very impulsive and he knows that he will hit his head and injure himself, which has caused many emergency room visits with injuries to his ears and his face over the years. And so we talk about life, I know Matt Holder talked about life transitions. Well, this whole COVID situation has been a huge life transition. As Barbie mentioned, while my son actually lives in a group home, he's bigger than me, he's stronger than me, I'm not able to keep him from hurting himself. The transition of not being able to go to school, not being able to see family for months. In fact, we had seen my son on March 11th and had not had an opportunity to see him again until July 5th. So this meant no physical eyes on other than FaceTime. And we were lucky to have that. One of the things that, as Barbie had mentioned, this aggression really comes out when these life transitions are happening. And in fact, over this last weekend, I almost ended up in the emergency room because out of nowhere, we were getting ready to go for a ride, his favorite thing to do. He was getting M&Ms, one of his favorite things to enjoy. And I got that arm with the splint so hard to the side of the head out of nowhere that I hit the ground and really was not able to hear out of one ear for quite some time. Luckily, I didn't black out, didn't need to go to the emergency room. But as parents, we understand where this is coming from. So specific to his health and well-being during COVID, we were able to get a teledental appointment. Now, my son goes to the dentist every 4 months, so it was out of his routine that he wasn't able to go have a dental visit. And during that teledental visit, there was reinforcement of his dental care. There was discussion about his diet. So that's the positive piece to what was happening. But the truth is, I'm a dental hygienist. And when I finally got to see my son's mouth on July 11th, sorry, it's upsetting, but his tissue and his mouth there was so much inflammation and so much bleeding that my heart broke. This is a young man who will allow a power toothbrush for as long as you want to use a power toothbrush in his mouth. He'll allow you to floss his teeth. So it was clear without eyes on. And of course, dental visits were deemed non-essential during COVID. That to me made absolutely no sense. And what if I hadn't been a dental hygienist? I would not have recognized what was happening in his mouth or have even been concerned perhaps enough to ask about it. But one of the things that we haven't talked a lot about, one of the roles as a dental professional that I don't think to this point have talked about during this symposium is the whole idea of less oversight. Very often, we as dental professionals know, as mandated reporters, that sometimes we are the only eyes at a dental visit that can see into the window of what might be happening to these individuals who are living outside of a home where they have parents, and like my son, maybe living in a group home where, yes, these people who are caretakers are amazing individuals. In my opinion, they're the unsung heroes in a lot of what has been happening during COVID. But very often, these individuals are living with people who are not family. So like my son, I had to rely on people who are not family to be taking care of him. And with no eyes on, with very little oversight, from March 11th to July 5th. So what that means is that the safety of many of these individuals has been compromised during this time. And he was out of routine, which of course makes him a little bit more difficult to take care of, and the individuals taking care of him are human beings. So things happen, and without a dental professional routinely having eyes on him and with no actual routine medical visits, there was no one to check his physical well-being. And as a parent, that just raises a whole other level of concern during all of this time. So dental visits are so important to these individuals, not just for their dental health, but in other ways that we may not think of as often. So again, I want to thank NYU for this opportunity and this platform to share the stories of our loved ones. Thank you, Ron.
Thank you so much, Karen. We so appreciate having you on the panel and your insights and stories that you tell. Our next speaker is going to be Ann Costello, the Executive Director of the B. Thomas Golisano Foundation. Ann, without further ado.
I'm here. Hi, everybody. I don't know if can everybody hear me?
Yes.
Yes, good. Good to see everybody. Good to be here. Thank you for having me. I wish we were in person. Appreciated President Hamilton's comments about wishing the clinic didn't need to be extraordinary. And I also picked up on an important word that he used that this foundation uses, and that's the dignity of the individual with intellectual disabilities. And I wanted to comment to Dr. Finkelstein, when he said he wished that every community had a NYU clinic that could see patients with special needs. I want him to know that we have one here in Rochester, thanks to the Eastman Institute for Oral Health, and we feel blessed to have that partnership and that care. Very little background on the foundation. It was founded 35 years ago by Tom Golisano, the founder of Paychex Payroll Processing, in honor of his son, Stephen, who has an intellectual disability. For 35 years now, we have supported agencies that care for, care about, and provide services to individuals with intellectual disabilities. And as I think about our history, over the past 35 years, most of the support in any given year is to the traditional services of employment and training, recreation, educational supports, residential supports, some capital needs, until about 10 years ago, when we met Special Olympics and Tim Shriver and Dr. Steve Perlman. We had not funded healthcare per se, and to be honest with you, I don't think the foundation could really understand what role they might play in the healthcare arena. So when I was asked to serve on this panel of family and provider, I thought, well, I'm not either one, although I do have a brother with intellectual disabilities, but I certainly can't speak firsthand like Karen and Barbie. And I'm not a provider of dental care, but I realize that the foundation plays an important role in improving and convening provider family to further and enhance outcomes for people with intellectual disabilities. So I thought I'd take you on the last 10 years of journey into healthcare by the foundation as we think about how our resources, our philanthropic resources, have been used to provide care or to help providers provide care. As I said, in 2010, we met with Tim Shriver, and he brought that Yale report. And to be honest with you, as he said, we were surprised that we were there to talk about health disparities. We thought we were going to talk about competitions, sports competitions that happen on the weekend. And he talked to us about the health disparities, the sickness, the preventable diseases that his athletes present on the field. Like Special Olympics, Tom, a man of action, said, we need to help you, we need to do something, what can we do? So over the course of a couple years, Healthy Communities was developed and born. It was developed out of healthy athletes that Dr. Steve Perlman had started with Dr. Paul Berman. And from Dr. Perlman, we learned how the foundation could better be a part of the healthcare conversation, the healthcare advocacy, and the healthcare delivery system. Steve has become a fierce mentor to me, and these next examples have Steve Perlman stamped all over them. One of the programs that we fund, clinics that we helped build in 2014 was in Niagara Falls, a very economically depressed area. Steve and I visited when we had the blueprints for the health clinic. They serve many special needs population. It is a federally qualified health center run by the hospital. And Steve pointed out to the powers to be and the architect that there was no dental suite in the plans for the community health clinic. And through his advocacy, through my encouragement, through dollars that were added to the proposal, we actually created a suite and forged a wonderful partnership with the University of Buffalo School of Dentistry. Another example is, again, in Buffalo, People Inc., Center for Community Health again. They expanded and renovated their federally qualified health clinic on Elmwood Avenue. And again, we encouraged the dental clinic, and our resources were used exclusively for the dental clinic. State of the art, it's wonderful. Again, a partnership with the University of Buffalo Dental School. We have a very close working relationship with the Eastman Institute for Oral Health, of course, and we have a specialty health dental clinic here. We have convened several times community task forces to learn from families like Karen and Barbie, and to learn from providers about the barriers that everyone has talked about today. We certainly can't fix them ourselves, but as a local community in Western New York and also in Southwest Florida, we are working to improve access to care as well as improve the overall health outcomes for people with IDD. We also have a wonderful program in partnership with the Eastman Institute again at a special needs school, Mary Cariola Children's Center. 450 children come from 64 school districts in upstate New York to attend Mary Cariola. Right now, we have 200 students, mostly the younger students, who participate with the Eastman Institute in the Smile-mobile. And the Golisano Foundation has supported the dental hygiene coordinator that is staffed, housed at Mary Cariola Children's Center. So this is a wonderful program. The van pulls up 3 times a month. Children are seen by the residents and the dentists. And this is a great example of not only children getting the care they need, but also to help with desensitization and the trauma that is often associated with a dental visit. They can bill Medicaid if treatment and services have actually been performed, but children who aren't ready to sit in the chair can walk up those steps 3 or 4 times a month, and eventually we do get them to sit in the chair, open their mouths, and receive the care that they need. You know, during COVID, as everybody has said, all these programs were on some sort of halt or hiatus, postponed certainly. And the foundation was able, I'm proud to say, react very quickly. We halted our regular grant process in the matter of days or weeks. And over the next 6 months, from March to October, all of our $2.5 million has gone to emergency COVID relief, if you will. We were able to turn around applications by our DD providers in 10 days. We actually had a series of 4 or 5 processes. And rather than the quarterly process that we normally take to process the applications. And we provided support for PPEs. We provided support for plexiglass dividers. We, in some cases, actually paid for core staff that were not reimbursed. You know, you think about not-for-profits that rely on fundraisers and events, special events, and Special Olympics included for so many of their programs related not only to the sports competitions, but to the special smiles and healthy athlete screenings. We were able to provide grants and supports to maintain what we could, what they could, what was allowed under state regulations for quarantine and for care. So we are active in the healthcare arena. We are advocates in any way we can for families, with providers. In New York State, the Golisano name, Tom's name, is pretty prominent and respected. And we tell providers and families that it's not always about the money, that if the Golisano Foundation, being your partner, can help move that needle, move that boulder up the hill, we're with you. In honor of Tom's son, we're here to help families like Karen and Barbie's, and we'll continue to do so for many more years to come. So I am so pleased to be part of this panel, part of this conference. Good to see so many friends and colleagues. Again, I wish we were there in person, but someday soon I hope we can be. Thank you.
Thank you so much, Anne. So I'm going to speak a little bit from the provider's perspective, and I can tell you that yesterday in my private practice, I saw 4 new patients, and the 4 new patients that I saw were developmentally disabled adults because they couldn't find anywhere else to go. And it was a little bit disturbing to me that, and as we as pediatric dentists have been fraught with seeing a great many of the disabled community. I don't think that there was anybody, as Karen and Barbie have said, I don't think that there is a community that has been impacted by COVID to any greater extent than the disabled community. These people have lost all senses of normalcy. They have all their programs that they normally would attend they're not doing. Their behaviors have become disruptive to their parents, to the caretakers, the providers, and their parents who are fraught with seeing these patients, being with these people 24 hours, 7 days a week, when a lot of the parents just need a little bit of a rest here and there, and they haven't had one. And Barbie and Karen's stories are a testament to that fact. So what we did at NYU is we wanted to change the paradigm, and so that we would train students to embrace this patient population and be able to treat them in their practices moving forward. Maybe not take them to the operating room or to do IV sedations, but to be able to treat them pretty normally on a day-to-day basis. So we want to provide a dental home for the disabled community on an ongoing basis. And we wanted to provide expanded education for our students to minimize their apprehension and fear in working with this patient population and treat patients with complex comorbidities. I was happy to say that our first patient was seen at the Oral Health Center for People with Disabilities on February 12th of 2019. And at that point, we were seeing between 35 and 50 patients per day. We had an expansion of the previous special patient care program that Charles had alluded to earlier, and a wide range of patients with complex diagnosis, patients who couldn't have done dental treatment previously, patients who are unable to transfer out of wheelchairs. We have the wheelchair tilt, which is very helpful. I can tell you that the wheelchair tilt, when we have patients that come into the center and they don't have to get out of their wheelchair and be transferred, they're so gratified that we have this wheelchair tilt for them. And you really see the smiles on the patients. And as it has been alluded to by President Hamilton, what we wanted to do was provide a dignified and respectful place for this community of patients to be seen. We have an autistic patients on the spectrum. We have a multi-sensory room, which was a collaboration between all the schools. Charles was I was fortunate enough to meet a lot of Charles's colleagues through the Tandon School of Engineering, the Steinhardt School of Occupational Therapy, and we got parents focus groups, and we had made some of the things that are in the multi-sensory room as a result of the collaboration between all the schools. Challenging moments we found have brought out the best in the faculty, staff, and students, and we found that that's the case. We're able to provide multidisciplinary care, have specialty providers every day of the week, pediatric, orthodontic, and endodontic residents on rotation, oral surgery, implant, perio, oral medicine, oral facial pain, prosthodontics. We have faculty on the schedule. We have various sedation options that we offer, nitrous oxide, oral conscious sedation, and IV sedation as well, with the hopes of providing general anesthesia in the future. We have a monthly craniofacial conference that occurs at the center as well. The student experience were vast. We had 12 D4 honor students for a full day every day. We had rotating D4 students that were spending about 6 weeks in the center. And we had rotating D3 students observing recorders for every 3 weeks. We had new rotation opportunities for DA, hygiene, and nursing students, and student organization collaborations. Unfortunately, COVID halted all of this, and the people who were impacted the most were the disabled community. And we all have been impacted greatly, by COVID-19, but I can tell you that the people whose my heart lies with are the disabled community. They have, it's been really, really hard on all of them. Post-COVID-19, we began seeing a limited number of patients on July 31st of 2020. We were having faculty-driven care, and we only were occupying 3 to 4 chairs. We had no students at the school at the time. We're utilizing postgraduate pediatric residents who have been an amazing help to us in seeing the pediatric patients. And the special patient care rotation began earnestly on September 8th, 2020. Unfortunately, we only have 10 D4 students and we're occupying 5 chairs because we can't occupy all 11 chairs that we have. So our numbers have been decreased tremendously, and being able to offer some of the services that we weren't able to offer have been diminished. So it's, again, been very hard on this community of people. Our hopes is that we will begin to bounce back and go back to where we once were. And I think we are now seeing between 20 and 25 patients a day, which we're happy with the hopes of, getting more and more as we go forward. So it's been a wonderful opportunity and an experience to be part of this center. I have seen people step up to the plate, students, faculty, and patients, and it's been a remarkable opportunity for us and for me to watch NYU educate dental students moving forward. My hopes is that as President Hamilton said, that every dental school in the country will have a center like this going forward, and that we will train all of the nation's dentists to become people who can advocate for the special needs community. Thank you very much for the opportunity to speak. It's been a remarkable day so far. And our last person on the panel is Assemblywoman Joanne Simon. So without further ado, Joanne.
Thank you. Thank you very much, Ron. And thank you to NYU and to President Hamilton and to the panelists on this panel and the others that I've watched. We learn a lot just from listening to each other, and it's been a very edifying experience. A lot of the things that have been talked about previously are things that we as state legislators deal with in a very sort of different way. We are by nature somewhat removed from what's happening on the ground in people's lives, and we rely on the stories of people like the moms, the practitioners, to tell us what's going on, where those gaps are, and to help us identify not just the gaps, but how we might be able to fill them. The budget process, which is really what drives so much of this, is in its sort of by its very nature, it's very, it's pretty insane. It's very menu driven. It's sort of incomprehensibly structured. And that's part of something that's been built over time with things added on and subtracted and changed around. And it's also very traditional in the sense that there are a lot of traditional assumptions that underlie so much of not just the policy, but also the structure of the budget itself. And so the issue about reimbursement rates, the issues about paying for service, we get those things from the field in some respects, but we also, for example, in childcare as an example we often use, childcare isn't between 9 and 5, right? A childcare facility needs to accommodate parents coming in earlier. Many of those parents don't work a 9-to-5 job. We have elder care requirements now. And so the traditional notions upon which some of these budget structures were built are no longer relevant in today's world. And certainly when it comes to an integrated behavioral health approach to dentistry for people with significant disabilities, there is almost no structure in our budget system that is particularly well suited to those needs and to responding to them. And obviously, the legislature passes a budget in big chunks, and then it goes to the agency, and that's where those reimbursement rates are set. And the Department of Budget can always follow through or not. And so right now in the state, we are struggling with the Department of Budget has not been paying out that which has been appropriated. And across the board, they're looking at roughly 20% cuts. And what they've done is said that very much what they're doing is just withholding payments to localities, nonprofits, and others with state contracts. And that's a very large universe. And the concern is if we don't get federal aid, that they will not fill that gap, that the state will not fill the gap with its own funds, that they would make those reductions permanent. And so now a lot of the conversation is advocacy on the part of the legislators to the governor, to the Department of Budget, to the Department of Health, to make sure we pay those not-for-profit providers who are now we didn't give them enough money to begin with. The issue about data for how much it really costs to preserve this population is very, very important, because otherwise you're left with the assumptions of the Department of Health. You're left with the assumptions of those people who are the sort of bean counters in the office, and they don't have any perspective on that, and they don't have any way of knowing that what they're doing is accurate from a service provider and the cost of providing those services point of view. So I certainly think it's great to provide that data. I think the legislators are helped by having that kind of information, because I will say that my colleagues are all, many of them are not particularly deeply knowledgeable on a day-to-day basis, but they all want to help, right? They all understand that these are problems, and they want to be part of the solution. And so they will advocate for you if they understand what the problem is and how they can direct efforts to provide that funding. One of the things we did was we had a series of hearings. We've had about 11 or 12 hearings on the impacts of COVID on various aspects of New York life, health, residential facilities, for example. We heard from people at pediatric nursing homes, group homes, nursing homes, obviously, and other facilities. And one of the big issues that came up is the role of families, and the role of families as part of that care plan, and how integral they are, and how important it was for people to be able to visit. And so, as people have talked about, it's been very, very difficult on this population in particular, for example, to not have anybody who could visit them, that they were really basically left there with staff who was overburdened, didn't have enough time, didn't have enough staffing to provide increased services, and that the family members were also not there to help with that care, because they provide that care, whether it's emotional support, whether it's physical support, whether it's someone like Karen, who is a dental hygienist and actually has medical knowledge and can assess herself. If she can't see her son, she can't help with that. And that's been true throughout various facilities. And if there was one thing that I took away, and I think my colleagues took away from those hearings, is one of the things we needed to address most quickly was the ability for a family member to be able to visit with someone who was in a facility, so that they could help. That was really important to the health, the mental and physical health of the person who was in the facility. And so those are things that we are continuing to work on. I know that we will be conferencing again on issues of revenue raising. What we don't know yet is whether we're going to get federal money and how much. Obviously, we need that federal dollars in a lot of ways to provide a lot of support for anything and everything. We need massive federal help, and we just don't have any idea whether that's going to be coming down the pike. And so we don't have very many answers now, except for the fact that we are in for potentially a world of hurt. And I'm very fearful, and so are many of my colleagues that are not-for-profit organizations, which are experiencing a great deal of financial distress because we are not paying them to provide the salaries and the services that they need to provide, that they will be able to continue. And then what do we do as a state if, in fact, we let down our safety net? And so those are some really very difficult issues that we're struggling with. And this center is very much a part of that. You shouldn't be the only ones out there. There should be more of you. It's expensive, and we don't have any money. and most people don't even understand what it is you do and why we need you. So I think this has been a great opportunity to explore these issues, and I'm really looking forward to working with everybody in the future to keep pursuing these issues and create more services like what you have here at NYU. It's a wonderful facility.
Thank you so much, Assemblywoman Simon. We really appreciate you being on the panel with us today.
I don't know if there are any questions coming in from the audience, but are there any other comments or follow-up that anyone on the panel would like to make before we go to the next group? I do want to thank Karen and Bobby and Ann and Ron sharing their personal insights here. And
Michael?
Yes, go ahead. I'm sorry, Ann.
Okay, I did
Karen.
see a comment come through from Dr. Paul Glassman talking about the program that they offer at his university. And one of the things that does come up and might address what he is talking about is, yes, the facility is extremely important, right? Because we need to have a place for these people to get the actual services. But one of the things I thought about a lot throughout this whole pandemic was, wouldn't it have been great if, for those who did not have parents who were dental hygienists and, didn't have an opportunity to be in touch with the people who were providing care, because look at what happened in my situation. I was able to stay on top, ask if they were brushing, ask if his diet was staying in control, and he still ended up very unhealthy from an oral health standpoint. And so imagine all those individuals, if they could have had some type of relationship with a dental hygienist throughout the pandemic, who could be guiding and teaching. I mean, I'm one person and I do a lot of training at his school, and for those who are caretakers in his group home, I do a lot of training, but I can tell you that that's not happening in a lot of places. And so there are those opportunities, as well as the great work that's happening actually at the facility at NYU as well.
Terrific, Karen, and thank you for that. And there are other questions coming in. So Stacy, Dr. Ripke, do you have any questions that the panel might be willing to respond to?
Sure, and thank you, Karen, for responding to that. We have something from the Executive Director of Oral Health Kansas, the State Oral Health Coalition in Kansas. They are working with a number of stakeholders on a project to establish dental homes for kids with IDD who are enrolled in Medicaid. Does the panel have any advice to offer about some best practices that they could employ? Are there any stakeholders that the panel would recommend they invite to be part of this work?
I think I can talk a little bit about that, because that's some of the work that we're doing with Project Accessible Oral Health, is trying to put together oral health coalitions through the engagement of existing coalitions that are specific to this population. I think the stakeholders that you need to make sure that are part of the conversation are most definitely payers, both private and those MCOs and others. And I also think it's important to have, obviously, academia. You want to have industry. You want to have, obviously, parent groups represented, national disability organizations represented. I think those are kind of some of the main contributors that need to be involved. And then, every state is looking to identify those directories that can be helpful. And I think through the engagement of, again, through the MCOs and the payers, there's an opportunity to survey and find those amongst those providers that do care for this population. So there's a lot of great work, and I'd love to help you offline. We're doing a lot of great things in New Jersey, as well as DC and Philadelphia. So if I can help, I would love to.
Great. We have time for one more question, Stacy.
Sure, and before this question, I just want to mention that Paul Glassman has shared, thank you to Karen, and mentions that the answer to consider is about dental hygienists in the community being connected by telehealth systems. So that's an additional consideration. Thank you for sharing that. An additional question that came in, what role do you see state agencies such as OPWDD playing in this work?
I assume that's for me, but some of the other, but both Karen and Barbie and Ron, I think would know as well. A lot of this is set by the Department of Health, but OPWDD oversees the services and the group homes, for example, for people with disabilities, and they have been actually very supportive throughout this COVID crisis. They are also, unfortunately, very limited, and so they've been looking to get better reimbursement rates as well. They have also advocated for changes in policy, for example, so that there could be better visitation. But they have been, there are times where the community is at odds with OPWDD, and that certainly continues to be the case in some ways. But overall, when it has come to the COVID crisis, they've been working a little bit more collaboratively with people. But they certainly do play an important role in, I believe, should be playing an important role in public information and in providing information to the Department of Health with regard to the populations that we're talking about here. Because the Department of Health are not necessarily people with that expertise, and people at OPWDD are more directly connected to the individuals themselves as well as their families, and really should be part of a collaborative effort where the policymakers and those that are in the position of providing the money for these services and supporting these services actually happening need to work with each other better so that there's a more common understanding of what the needs are. And I think that, one big problem, of course, is that in an emergency, especially when you think that emergency might be 2 months long, decisions are made because for 2 months, we can all, get by kind of thing. But that emergency has lasted much longer. And so at the bottom of the list, or not even on the list, are people with developmental disabilities. And that's true for education, it's been true for healthcare, it's been true for those residential facilities as well. And it should be the role of OPWDD to elevate that and to be there at the table and make sure that that people with developmental disabilities are not low on the list, number one, and make sure they're on the list in the first place, which is.
Well, thanks again to our panelists, Joanne, Ann, Bobby, and Karen, and of course to Ron, who serves as our clinical director of the Oral Health Center for People with Disabilities. And we're grateful to all of you for sharing your insights, and especially to Ron, from my point of view, we're so grateful to him for all the work he's doing on behalf of this population. So thanks to all of you, and wonderful, that's a great panel discussion, so thank you. Let me now move on, if I may, to the third panel, which is going to discuss the impact of COVID-19 on the disabilities community. We heard a little bit about that already. And it's my honor and privilege to introduce a dear friend and colleague of mine, John Kemp. John is president and CEO of the Viscardi Center, a non-for-profit organization providing a lifespan of services that educates, employs, and empowers people with disabilities. A renowned, sought-after global speaker, John is widely respected for his many accomplishments, both in the corporate and not-for-profit worlds. As a person with a disability himself, he inspires others to achieve the impossible through knowledge, experience, vision, personality, and persistence. On a personal level, I know he inspires me. It is a privilege to introduce my friend, John Kemp.
Gosh, Michael, thank you very, very much. That was very kind of you. And it's just such a pleasure to be with you and with everyone. I can't tell you what a sparkly, fantastic group of presenters and leaders who are on this program. I think it's just wise of NYU to be able to put this on and to gather up the speakers and to see so many good friends. When I look at all of the leadership at NYU and Charles and Ron, you've acknowledged very well, President Hamilton, my goodness, came out to be a part of this, wonderful. Robert Glickman, who's on our panel, which is great. And you, Michael, thank you very much for what you're doing. It's just incredible. To have Henry Schein and Stanley Bergman and Steve Kess, who I love and admire greatly and consider an extraordinary friend. You just had on Joanne Simon, who I've known for many, many years since she was an ADA attorney in Washington, D.C. And here she is, an elected official serving all of us and primarily people in the Brooklyn area, but all of us, and representing the interests of people with disabilities at the state level. Neil Romano, who's the chair of NCD, awesome. Shriver, Tim Shriver, my goodness. Everybody knows the family, but to realize that he substantively gets and understands and lives this vision of what life can be and should be like for people with disabilities is incredible. And Steve Perlman, who's the wizard of all of this, and he's been acknowledged. I think he's an incredible guy as well. Then you got to hear from Barbie Vartanian, who is our director of the Viscardi Center's Project Accessible Oral Health, which is looking at the broad picture of policy and reimbursement issues, which drive so many of the decisions. But I loved what Ann said earlier. It's about the dignity of the individual we serve every day. And that is really at the heart of what we're trying to do. To think that we're clawing our way up to get to equal still in 2020 is difficult, but it's true. And then COVID presents itself to us in very difficult and unusual ways. And I will just say that just to tell you that the way we're going to operate this wonderful panel, and I'm so proud to be on with you all, is that we're going to have a conversation among ourselves in front of you, and you all are going to probably want to ask some questions, so be sure to put them into the Q&A box, and we will try to get to them. And we'll have maybe 4 or 5 questions that each one of them will have an opportunity to address in fast, short order. But to put a little context to this, COVID and people with disabilities, not to mention what the president announced today, I'll just say people with underlying health conditions are 1.5 to 4.5 times more likely to need hospitalization than people who don't, and people with overlapping conditions 5 times as likely to get seriously ill and risk death. People in the higher age groups, 65 and older. And here I find myself, gosh, I'm in that age group and I have a disability, and I probably have some underlying health conditions as well that would qualify me. We're between 4 and 13 times more likely to catch COVID-19. And the likelihood of dying from COVID-19 is between 30 and 630 times. It's so big, I don't think it's large, it's huge. So COVID has a direct impact on the quality of life and our ability to access healthcare writ large. And this session is really about health, equity, and social justice. And that's what we want to frame this as. So I want to just thank my panelists, and you see them on the screen, Dr. Robert Glickman, Dr. Larry McReynolds, Marco Damiani, and Anastasia Somoza, who I've known about since she was 8 years old and is an extraordinary advocate with the city of New York and works for the Speaker of the City Council. And they'll make their introductions themselves, but we've broken it out into four questions and maybe a 5th one if we have time to get to it, which is what are the solutions? But the first question that I'm going to pose to the group is, what are the implications of COVID upon our community of people with disabilities, and especially as it relates to dental care, oral health care for people with disabilities? And I'm just going to say, Marco, would you like to go first? I'm going to put you on the spot.
I'd be happy to, John, and thanks to NYU for hosting this very unique symposium. I think it's incredibly valuable. So COVID-19, as John has said, has had an incredible impact on people with disabilities, and it's actually laid bare the enormous inequities in our society. And I think we can talk a lot about some of the details and the comorbidities. But let me first start with what Neil Romano said earlier today. The groundbreaking Ziegler study out of Yale in 2000 really did begin to create an enormous attention on this population, and it inspired me to get more squarely involved in the healthcare space. And while we've made progress in that area, no doubt, we have tremendous work to do. And I think one of the most glaring examples is on August 8th, the CDC released risk multipliers and comorbidities associated with COVID. There were 8 risk multipliers and about 24 comorbidities for the general population at risk of hospitalization. We've applied those risk multipliers to hundreds and hundreds of people that we support and are now doing it for several thousand people. And as you can imagine, there's absolutely no reference or consideration for people with complex needs, people with disabilities, and their risk of hospitalization for COVID. So while we can say there's been a lot of good work done around COVID, especially in New York, and I think that's true to a great extent, look at the gap that we have. We are finding, as John mentioned earlier, that people with IDD have a likelihood of dying and being hospitalized at a much greater rate than people living in New York without disabilities. We're finding out that the access to some basic stuff like PPE, as tough as it was absolutely disastrous for this population. So the implications are very clear, that we already had a substandard model of care for people with IDD and disabilities generally in this country, and now we really see it completely naked, exposed to everybody, pardon my explicit language here, but it means we need to do something much more specific. And I think that means, number one, we really do need to look at this more carefully. And I'm really proud to say that the work that we're doing at HRC New York City has been to include many other IDD providers around New York State. We're now working with the Syracuse University Maxwell School of Public Health. They have already published several academic articles on the risk of COVID-19 on people with disabilities and the downstream challenges that we're likely to experience. And also, quite frankly, the lack of response from government. I know there may be some government officials on the Zoom here today. I'm not pointing fingers, but when providers and academic institutions need to step in and provide public health assessment and possible solutioning without government involved, that's not a great model. I know there's a lot of distractions in the world right now, but there is a tremendous amount to be learned here. We need to move forward. And I think this symposium is a great beginning toward that end.
Excellent, Marco.
Thank you.
Thank you. Larry, would you just introduce yourself and take a shot at the answer, please?
Sure. Hi, my name's Larry McReynolds. I'm the Executive Director of the Family Health Centers at NYU, and I run FQHCs. And I was so glad to see that so many of you know what FQHCs are. But for those of you that don't, they are primary care clinics that are federally funded to help those that have access barriers to care. It mostly focuses on the general population. There are some that have more of a focus on special needs populations. And so that's what I do. I wanted to add to the question by saying that, you know, in the federal preparedness and in the state emergency preparedness, the disability population is often left out, and it's always focused on hospitals. And even as you hear now, the second wave of COVID is coming. What is the preparation going to be? It's still hospital focused. Everybody was going to flatten the curve so that hospitals were not going to get overwhelmed. And I think that, you know, everything now is statistical modeling. So where are the high-risk populations? We know that they're in nursing homes, and then we know they're the disabled population. So how are we focusing education, PPE, provider support in those high-risk populations? New York City schools just reopened 2 days ago, and already one school in Queens has closed because it's a school that has a special needs program, and children in that special needs program, you know, came back COVID positive. We still haven't learned, even 2 days ago, in the midst of this pandemic, where we need to concentrate our efforts. So I think that there needs to be better counting of the disabled population and effects of COVID, raising equity, and then inclusion in disaster preparedness and delivery systems.
Excellent. we are not included in many of these activities and the planning, not included and not at the table. So our voice is not heard. So thank you for raising that. Dr. Glickman, I'll call you Robert because that's you're my friend. Robert, what's your perspective on this?
Well, one perspective, of course, is I'm humbled to be part of such an unbelievable organization, working with John and hearing everybody speak today. I don't think I could frame the problem better, but just a little, some details, and then unfortunately, I'll give you a jaded viewpoint from my perspective. So from March almost through July, New York State mandated that all dental care except emergency care cease. For this state, that created a problem that was just waiting to fester into something much, much greater. Simple things like Karen expressed, inflammation that went unchecked, oral lesions, simple dental problems that may not require anything more than a simple restoration now would require a root canal treatment, or if a root canal treatment can be done, an extraction. Patients presented with severe infections, in some case septic issues. So the hospitals were full of COVID-19 patients. More significant medical and surgical needs actually were not cared for initially. The risk of spread of COVID among dental patients due to aerosolization was a huge concern. And imagine that now in a population that often is uncooperative. Most of the care was just simply antibiotics and pain medication, and inevitably care was deferred until places like our center were able to reopen. Why do I say I have a jaded perspective on this? I've been fortunate to spend my entire professional career in an academic environment. And the reason I say that is some of the cost was almost irrelevant to me because I did it as part of my professional and academic responsibilities. But what always got me is that when I saw patients who were disabled, and I guess I have to put this in too. We've mentioned some numbers, 6,000 patients a year, 3,000 patients a year. There are over 40 million disabled people in the United States. That's not going to cut it. So the patients that I saw were either referred to me or I would visit in the emergency rooms, came to these environments because that was the last chance. That was their last hope for care. Now, why am I jaded? If any of us walked into an emergency room with a stomach ache, the hospital would keep us in the emergency department, or we would get admitted to the hospital for days on end until they discovered what the cause of that stomach problem was. Now, through my entire career, if you admit somebody with a disability to do dental work under general anesthesia in a hospital, it will be denied. The care will not be covered because it's a dental problem. And unless there's a special insurance availability, there will be no reimbursement, not for the provider necessarily, but for the hospital. So the incentive is never to place, and will never be unless this is changed, to place individuals with disabilities on the same level as anybody else. And so what I see this is, and I know Marco said this and others have said this as well, this is a failure of legislation that really treats people not special, but just simply equally. And so when I am called to the hospital, it's often in an emergency room, it's often in the middle of the night, and the only care that I could deliver is more of the extraction nature. That's really, and I've learned this from Ron at the center, many patients, this can be avoided. But unless we're going to change the nomenclature, the medical nomenclature of this, we're not going to be able to provide care on an equal basis. And it's not realistic to think that all the care can and should be treated on an outpatient basis. It should be maintained on an outpatient basis or prevented on an outpatient basis, but there's always going to be some need for care to take place in a hospital. These individuals should not be treated any differently than anybody else with a medical condition. And so my perspective is a bit jaded because of the situation that you have to argue to actually have a hospital admit a patient under the best of circumstances. Now take a situation where COVID comes in, and it's not going to stop, very, very shortly. We're not going to have a vaccine. And I know that's one of the questions we're going to answer in a few minutes. But vaccine is not going to be a magic bullet where a light switch is going to turn around and all of a sudden our priorities are going to shift. And I really see that as a legislative failure, and it's similar to what Marco says. So, and if time permits, I'll end on a less jaded, on a more positive note on some of my experiences. But up till now, it has not been, the most positive way to see things. Thank you.
Well, knowing what the problem is gives us a chance to solve it, and it's got to be solved now. And it's 2020 and going forward, and the fact that we're still fighting for our basic civil rights and access to health care is just terrible. It's just a terrible statement. So we can do better, and we owe it to people with disabilities. And now the ever shy and humble Anastasia Somoza, who might have a couple of thoughts about this whole area. And Anastasia, so proud of you and proud to have you on the panel.
Thank you for the fantastic introduction, John. I'm humble that I'm excited that this opportunity has allowed us to connect personally. And thank you so much to all of the NYU staff, particularly those at the School of Dentistry, for inviting me to participate today. I'm happy to be here. So I am participating today in my official capacity as community liaison for the Speaker of the City Council, Corey Johnson. And in that role, I work to connect the main population that I serve in that role is people like me. The council before I came on had never had a liaison in their community engagement division that focused on connecting New Yorkers with disabilities to what their local elected officials were doing. So I was asked by Corey when he came in as speaker to fill that role. And as a lot of the previous speakers have said, I don't have a specific expertise in dental care or anything like that, but doing this role for the speaker has allowed me to collaborate with a number of organizations that focus on increasing access to healthcare for New Yorkers with disabilities. And the collaboration with NYU and the opening of the clinic has been one of those opportunities. And in terms of adding to this specific question, the impact of COVID-19 that we've seen on people with disabilities, I've heard anecdotally through my work for the city as well as my own advocacy work that dental care under the umbrella of all healthcare is still not being prioritized in the pandemic. So in other words, people with disabilities are going back to see doctors now, but dental care is at the bottom of the list. I've been in communication with people who are working in group homes and nursing homes, and we're being told that individuals with disabilities, IDD and developmental disabilities are not being taken to see their dentist because it's not considered a priority in the time of COVID because they have to deal with how do we make sure patients keep their masks on and a whole host of other issues. So in the pandemic has only unfortunately exacerbated some of the issues that we already know, that healthcare for people with disabilities, in particular dental care, which we've all learned more about today, is just unfortunately not a priority, and COVID-19 has not made that better. It's exacerbated the issue. And I think another related issue specifically to the pandemic is that a lot of people with disabilities rely on home and community-based services. So the people, even those actually that are in group homes, rely on the people that do the direct support, professional care, to show up to those group homes, or in my case, to show up to my apartment to help me get out of bed. And what we've seen through COVID-19 is the home care workforce is not being addressed in the same way that doctors and nurses are being are gaining access to the necessary PPE. If there are still shortages in hospitals, which we've seen, there are definitely significant shortages in access to all of the personal protective equipment that allow group home staff and all of the staff that do the direct care in order to show up. And if they're not showing up to assist the individuals to get to the doctor's appointment, these problems are only going to get worse. If the people who support people like me to live our daily lives and to access the care that we need can't come to work because they're scared for their own health and safety, these problems are, as I said, only going to increase and get worse. So supporting the people that support us, in other words, is key to making sure that we can maintain our independence and our overall health.
Excellent. Thank you. Anybody want to comment one more time before we move on? Okay, I'm going to move on to vaccines. And we think that vaccines are absolutely going to be here, but maybe not before the election and maybe not until early next year. And there'll be quite a long time before we get them vetted and that they're safe and that they're produced in mass quantities and distributed on an equitable basis. One of the questions that we've been talking about, and we had a little discussion beforehand, was, are people with disabilities included in the trials, in the phase 3 trials for the vaccines in a proportionate and relevant number so that our conditions are factored into the ultimate decision on what kind of vaccine is ultimately going to be, or vaccines are going to ultimately be approved. And Larry, you referenced that in your comments, I know as well, and I might just put you on the spot and say, would you like to lead this part of the discussion?
Well, I would make some general comments that the studies that I know that are going on in New York are of the general population, and that they are not inclusive of special populations. And, you know, the current reasoning is, well, they're trying to, you know, speed this process up and that would slow it down. So let's not, you know, include designated special populations. I think that, you know, getting back to the numbers, that all research should be equitable, that it should look at all of the population so that its acceptance when the vaccine actually comes out, people will say we were included in the development. We're not being used as guinea pigs in the administration. And I also wanted to raise the point about the caregivers, that the caregivers need to be seen as frontline workers. They need to be prioritized in the distribution of PPE and in the availability of vaccines. Whenever any vaccine comes out, there is going to be a priority list, and we need to make sure that caregivers are included in that priority list, as well as those most vulnerable should be prioritized.
Excellent. Robert, you raised it first. I'm just going to say, please weigh in here.
Well, Larry covered every item I was going to say. It's clear everyone would agree that the frontline healthcare workers and essential personnel, police, fire, need to be vaccinated as early as possible. But then the next list should be the most vulnerable, because they're not only at most risk, but the care that's going to be required if they need this is going to be an inordinate amount of drain on resources. just like it was when COVID shut down all the hospitals and saved all the PPE that they could save for the hospitals. Very, very hard to get equipment outside of those arenas. So again, the most logical thing to do is to select those most vulnerable, and they should be the ones who get the vaccines the earliest. Very interesting about, Larry also mentioned research. And, unless a study is particularly about a specific group, very, very hard for this group to be recognized or to volunteer to participate in research unless it pertains only to, the particular aspect of their condition. And that's probably a lack of inclusion and also education on the part of both sides.
Mm-hmm. Excellent. Anastasia.
I would say I agree with what Robert Glickman just said, that we should, on the one hand, of course, be at the top of the priority list because for the reasons he mentioned, but one of the things that I want to make sure happens before not only everyone in general gets access to the vaccine, but in particular people with disabilities, that we make sure that we're not used as, giving the vaccine too early or potentially used as guinea pigs to make sure that the vaccine is actually safe enough. Because for those of us, part of my educational background is in political science and in human rights and studying social movements. And if you look at the history of the disability rights movement, we were often, especially for the medical community, we were seen as these oddities and often used as guinea pigs, and our bodies were exposed to doctors and nurses sort of indiscriminately throughout history to quote unquote fix our broken bodies and to, in a lot of ways make us, less disabled or, less difficult to look at visually than the rest of the population. So we want to make sure in the distribution of a vaccine that doesn't happen, that people with disabilities don't feel like we are being used before the vaccine is proven to be safe. So absolutely, I would get a vaccine, and I want to have the vaccine, but I also don't want to be the first, a part of the first group of people that gets it. I want to make sure it's actually safe before it's put into my body instead of the opposite.
Good perspective. Marco, please.
Yeah, I want to emphasize the ethical dilemma here. We're talking about last in line for quality care. We don't want to be first in line for dangerous care. And I don't want to oversimplify it, but that's what we're talking about right now. And it gets back to some of the conversations earlier around the balance, the fact that people with disabilities are people. They should be included in the process of how we deliver and assess the impact of quality healthcare. And I want to take this one step further and say, it's not just about the vaccine. It's about the way people with disabilities right now are getting COVID-related treatments, how they're being seen in the hospitals, how they're being able to access COVID-related care. And we've unfortunately had experiences where they really haven't had the best access. There have been, in some cases, some dramatic cases, people were going into end-of-life situations when they shouldn't have been, and our doctors had to step in. I hate to even have to say that in 2020, but I think there's a line here between the vaccine dilemma and the overall care dilemma, and it's grounded in a life that is valued less than somebody who's typical, whatever that means. So I think it is an ethical dilemma. It's also a very practical one around advocacy and healthcare generally.
Excellent, excellent. Appreciate the thoughts. And when we talk about training and general awareness for dentists and dental students, how do we present this? We've got a model program at NYU Oral Healthcare Center for People with Disabilities, hearing about David Chu talking about in California, a year to a 2-year wait. And at NYU, it's a week, and it's unusual and it's extraordinary. And we're fortunate to have such a great resource in our metropolitan community here, just amazing. But what about the training that goes on? We know the ADA has recently changed some of its mandates about what they present. The ADA that's in Chicago, the American Dental Association, not the one that we grew up with loving, which is the Americans with Disabilities Act, us advocates. But the ADA in Chicago has said dental schools have to do a better job of educating students going through their programs on various factors such as disability, people with disabilities. And disability is a very wide and broad term, as you've heard today with Barbie Vartanian and her son with autism and other people with have different disabilities. What are we doing about training and educating our students and the dentists who are already through the system and out into the community? What do you think? Who would like to go first?
I can take it first. I think, and again, this doesn't only apply to the dental schools and dentists that make up our healthcare system, but the whole healthcare system, including those in the field of dentistry. I think the biggest thing we need to do to improve that, as some of the earlier speakers and panelists have also touched on, is making people with disabilities an integral part, again, which means making sure that as students go through dental school, they have training and interaction with patients who have wide-ranging disabilities, so that their first interactions with people like me are not when they're already entering the profession and either working at clinics or in some cases working at private practices. So you want to make sure they're getting this training as a part of their education. And then the second piece of it is to make sure that there are people with disabilities in the field. So there are people with disabilities they're interacting with at the schools, again, in these academic and training settings, but also working in the field, because people with disabilities are able to be practitioners in the healthcare field. And if you have people with disabilities working in the field, that is what's going to change it, I think, in the most significant way, because rather than talking about us without us, we can be a part of making it better and increasing the access to people like us. And obviously, if we are part of that system, if we're dental assistants, if we're dentists, if we're part of the system, it's going to get a lot better, a lot faster, because you can ask us and talk to us about implementing those solutions if people like me are actually more integrated in the field of dentistry and healthcare overall.
I would add to Anastasia's great comments that there's no social justice or racial equity without health equity. And while the technical training and experience is absolutely critical, the exposure to a broader population of people that require great health care and dental care. What about implicit bias training? What about professional ethics, which I'm sure is included in medical and dental school training? I don't know how much. Social determinants of health, we talk about it constantly. How embedded and ingrained is that in a dentist or a physician's awareness of when they see patients? It's more than just a technical clinical transaction. It's got way more to it than that. And I think some other comments made earlier, especially by Dr. Finkelstein, the payer system impedes our ability to see more complex patients. more complex patients, I think, tend to be in Medicaid and Medicare, and people behave the way they get paid. Let's be honest with each other. And if the payment system doesn't encourage the ability to see more complex patients, you don't learn. You stick with your own biases. You don't see the enormous benefit of actually being able to do a great job with complex patients. If you're a clinician that really cares about being the best you can be, why wouldn't you want to see some of the most complex patients? So I think the payer system is in some ways corrupt around supporting a narrative that can have people with disabilities get better care. And I think all the stuff that Anastasia said about very technical training is absolutely critical as well.
Great, excellent. I want to interject myself here just into this discussion because at the Viscardi Center, we have a school for medically fragile children, and we're very careful and very worried, and we are as sanitized and as clean as we can possibly be. And if any of our students who are medically fragile come down with COVID, it'll be from outside of this place. It'll be from the drivers or the people on the street or wherever they might be going. But we are very cautious and concerned about them. We also look at, through our Project Accessible Oral Health, which Barbie is running, and we look, what is the long view of where we're headed? And that is that the neighborhood dental office is physically accessible, it's programmatically accessible to us, and it's operated and run by people who are culturally competent to accept the different needs of people as they present themselves. That's a tall, long order. That's a big challenge for the educators, the dental educators and the trainers and even those folks who are going through continuing education programs to be able to come back around once again and possibly have the issue of disability and the broad breadth and depth of it to be included in that continuing education process.
No, I think patients certainly see us as our primary responsibility is to look after their health and well-being. Dentistry just happens to be the technical part of the body that we concentrate on. It's the exposure and the experience that these young individuals need in order to gain confidence that they are, as President Hamilton said earlier, not extraordinary, but ordinary. And I think historically, the exposures were very limited. Only a few students had the opportunity to partake in this, and they would, if they had an interest, they would pursue it. If they had a family member, they might pursue it, but otherwise the majority of students did not. And hence, that's why dental practices today, one reason is financial, of course, but the other reason is they don't build their practices to accommodate all different types of patients. Well, now as schools, perhaps somewhat under a mandate, perhaps because of centers like ours, all students are now getting an exposure and an experience. And, you know, I wish we could bring Ron back for a second, because you just have to see the attitude of these students, you know, showing up early, putting in extra time learning about some of the various disabilities, you know, diving in, you know, completely surrounding patients in order to try to help them. They don't see it anymore as different. They see it as part of their obligation. And that's you know, what we've just heard, you know, by the last two speakers, but I think that's really the only way to do it. It has to be part of day-to-day activities.
Great, just great. Larry, any comments?
You know, medical school, your training is largely based on spending time in the prevalent conditions of a population. So diabetes, cardiovascular disease. And disability is a large prevalent condition in the population, but yet that's never really seen as, oh, well, that's a condition or population where medical school students need to spend some of their time. And then I could move that along with, you know, psychiatry, OB, dentistry. So I think there does need to have that lens of equity in education. And I think that the other thing I think that is encouraging as Black Lives Matter and equity discussions are continually elevated, medical schools now are asking their residents to look at their panels and look at our Black diabetics in better control than white diabetics. Did you have equity in screening for cancer amongst the patients on your panel by race? And I think it would be an interesting idea of, well, what is your management of persons with disabilities in training? How many? What conditions? What were your outcomes?
You have raised the issue of intersectionality, and I do think that we see people with disabilities who are Black or have other even second or third level underlying conditions really can compound the problem and exacerbate this into a crisis. And this is really kind of where we're facing right now. Project Accessible Oral Health is looking at the reimbursement mechanisms and the policies. And imagine taking on Medicaid. We're taking on Medicaid because if a person with autism needs 5 visits to a dentist to get acclimated to the lights and the noise and the utensils and the other devices that they're using, then they need 5 visits, and the dentist should be reimbursed properly for that care. Not one size fits all, and that's where the breakdown is, that people with disabilities don't fit easily into a category. So we are trying to take on the big issue as well in the reimbursement. And Marco, that's what was driving your point. So Michael, I will pass it back to you and just say to my panelists, my fellow friends, thank you very much for a great job.
Thank you, John, and thank the panelists. We have a couple more minutes for a couple of questions if the panel is up to it. Stacy, do you have any questions that the panel might be willing to address?
Yes. Karen Raposa from the last panel would like to thank Anastasia and notes that her son Tommy's direct support providers have struggled to gain access to necessary PPE in order to safely take care of him in his group home as well. And she adds that a staff shortage has also been a problem. So how do we raise this issue with our state and federal agencies?
I guess one part, I guess Karen's asking that for the state of Massachusetts. I know in New York State, there's various means of obtaining PPE. I also know that Steve Kess, has provided a lot of assistance in helping us with that. So, working with our own dental societies, state, as well as partnering, with people like Shine, that has really benefited us greatly here at NYU for sure.
And
Benefited us at Viscardi too, by the way. Thank you.
just to add to that, I know my mom is also a well-known advocate here in the state of New York, and she's on a bunch of listservs, and we both work together in this advocacy generally. And I know at the start of the pandemic, one of the things that my mom succeeded at least here in New York, for example, was to make sure that if a person with a disability like myself needed to go into the hospital during these, with all of the COVID restrictions in place, she made it so that a parent or a primary family member or caregiver could visit that person, obviously wearing the right protective equipment, but she made it so that, for example, if someone like myself or my twin sister Alba ended up having to go to the hospital, we would be allowed to have a parent, because part of the other issue in trying to get the right care, as other people have alluded to, is just understanding what the patient, what somebody like me or my twin sister who's nonverbal, or somebody with autism that might have difficulty communicating, that's part of the problem in accessing the right care. So if a parent is allowed to be present, that's one of the ways that we're tackling that huge question. And here in New York, my mom and I are working with the state, OPWDD, and other elected officials to make sure that we address the lack of PPE issue so that people can get the in-home care that we need, as well as access to the appropriate health care during doctors' visits. So.
If I could add something really fast.
Please.
The federal-state partnership here is absolutely incredible. And not incredible, essential. It's not incredible, actually. And the funds that are not coming to states to manage COVID is a major problem. We support over 5,000 people in our workforce. We pay them premium pay for months. We can't do it anymore because there's no downstream money coming from the federal government. In addition to that, FEMA just changed 2 weeks ago its PPE reimbursement methodologies to dramatically restrict access to PPE payments for any place other than a hospital or medical practice. So you got to talk to your federal people. You got to advocate with states. The workforce payments aren't enough, and PPE access is really threatened right now.
Great.
Terrific. And anyone else on the panel want to make one last comment? If not, I want to thank John for moderating the panel, and also to Anastasia, Robert, Larry, and Marco for their comments and their support of our programs here. Each one of them is a big friend of ours, and we appreciate all the guidance and expertise that they all have given us as we try to address the access to care issues for people with disabilities. So thank you all very much.
Thank you, Mike.
Okay. Now it's my pleasure to introduce Stan Bergman, who will serve as moderator for the fourth and final panel, The Importance of Public-Private Partnerships in Advancing Access to Care. Since 1989, Stan Bergman has been chairman of the board and CEO of Henry Schein, Inc., a Fortune 500 company and the world's largest distributor of oral healthcare products and services to office-based dental and medical practitioners. Stan serves as a board member and advisor for numerous institutions, including NYU Dentistry, where he co-chairs the Dean's Advisory Council. Stan is a great friend of the college. He supports many of our initiatives, including the NYU Dentistry Henry Schein Cares Global Student Outreach Program. Please join me in welcoming Stan Bergman, a truly remarkable human being. Stan?
Thank you, Mike. It's really great to be here. For some reason, I've just been unmuted, so good. Thank you. It's a real honor to participate in today's discussion. The topic is near and dear to the heart of everyone at Henry Schein, particular Steve Kess, who first introduced the idea to me personally about a decade ago. I have to tell you, a decade ago, I was not aware of the degree, the number of disabled people in this country and around the world, and the disadvantage disabled people were put in due to lack of health care. So Mike, thank you very much for facilitating today's discussion. Of course, Dr. Charles Bertolami, the Dean of NYU College of Dentistry, thank you for providing the focus that this area requires. I was very pleased to see Dr. Andy Hamilton, the president of NYU, also introduce comments today, which makes me feel very good that at the end of the day, this is on the top of the NYU agenda. Pretty terrific. So the panel members today are Dr. Rick Radar, member of the board of the National Council of Disability, Steve Kess, Vice President of Global Professional Relations for Henry Schein, Stacy Hengsterman, CEO of the Special Olympics New York, and Dr. Amir Musi, Professor and Chair of the Department of Pediatric Dentistry at NYU. Every single one of these participants is really committed to the whole area of providing access to care to people of disability. At Henry Schein, we have seen the power of public-private partnerships be very effective for many years, whether it's in the disaster preparedness or response arena. Of course, to strengthen health equities is an area we are focused on through public-private partnerships. Of course, to further wellness, prevention, and oral health, as Primary care is an area where public-private partnerships have worked. To strengthen health security through better coordination and enhanced supply chain sustainability, another area that has worked for us, partnership arena, and in the area of advancing access to oral health for people with disabilities. I'm pleased to see that this is an area that has worked effectively for the last few years, and much of our public-private partnership work started at NYU, the dental school, through Project Accessible Oral Health, as an area that we became a founding member in 2017, as the health provider partner for the Special Olympics Health Athlete Program over the last few years, and in our work with the National Council on Disability since 2019, about a year plus ago, to expand dental care for people with disabilities, to expand development and utilization of products and equipment for patients with disability, a key area. I heard the comments on PPE. We'd love to work with you on that area. We have PPE in adequate supply today, and the states, certainly New York State has. Another area is to assist Americans with disabilities, of course, accessing care, which has been very, very important. And yes, the reimbursement and financial areas are important too. These are all areas that we're trying to address through public-private partnerships. So we're very pleased to be here today as part of an initiative to advance public-private partnerships in the area of providing access to care for people with disabilities. A huge number of people have these disabilities. It is our job, I think, in academia, in government, and in the private sector, working with healthcare professionals to provide access to oral care. So thank you to the panelists for participating, and NYU, thank you for putting on this program. So to all four of the panelists, where have you seen the most effective examples of multi-sector partnerships? And why do you believe those partnerships were so effective? Who wants to go first?
I'll go first. Is that okay?
Sure. Perfect,
Okay.
Rick. Go ahead.
Thank you, Stan. In my mind, the reason that multi-sector partnerships are so effective is based on the old adage that one can't do the work of two, but two can do the work of three. My earliest experience and introduction to public and private partnerships is probably a far cry from most of my colleagues on the panel. But to my New York native colleagues, Neil Romano, Steve Kess, Steve Perlman, Alan Finkelstein, and my brother, Dr. Phil Rader, an NYU dental alumnus, will probably remember and also appreciate this. When I was in elementary school in Brooklyn, PS 244 in East Flatbush, I was in the 6th grade, and I was picked to be a school crossing guard. They gave me a badge and a white plastic belt and a cross strap, and I was responsible for ensuring that the students safely crossed the street. It was a partnership between the public schools and the AAA, the Automobile Club, and it worked. In fact, it worked all over America since 1920. It was a model that still works today, and we certainly see it in healthcare for the underserved. The model first identified unmet needs and then attracted groups who had a mutual interest in producing optimal outcomes. One partner brings a unique skill sets, resources, and expertise, and the recipient partner helps in identifying the inherent obstacles and challenges, plus a litany of historically failed attempts. Together, they form new battlegrounds, and they help to identify what constitutes efficacy and efficiency. There was a very special novel partnership that I was involved with several years ago. Military doctors typically provide health care to the ranks, Army, Navy, Marines, and Air Force. The patients are typically young, healthy, and active servicemen and women. But there are over 150,000 military families that have dependent children with special health care needs. Military docs were not equipped or skilled to treat this group. The Department of Defense approached Exceptional Parent Magazine, where I serve as the editor-in-chief, to provide educational assistance to the military physicians and caring for children and adults with complex disabilities and disorders, including metabolic diseases, mitochondrial disorders, inborn errors of metabolism, sensory processing, and neuromotor diseases. We identified those physicians with an expertise in those areas and created an educational and consultation resource to assist military docs who are responsible for their care. It worked because it was a win-win partnership. It alleviated the burden for thousands of military families facing deployment and resulted in high retention rates for service families previously preoccupied with getting specialized health care for their children with complex health care needs. So that's another example of a novel partnership between private and public sectors.
Dr. Rader, that was perfect. Who's next?
I'll go.
I see Stacy, you're on the one side of the screen, so please go
All right.
ahead.
Well, thank you. It might be cheating a little bit to say a great example of public-private partnerships is what we're really doing right now. So having these forums, having these government leaders come in, having the private sector, organizations like ours and the not-for-profit discussing this, really somebody listening today learned something new. Lots of people did, and they're going to take that and they're going to do better. I know that. I've been the president and CEO for Special Olympics New York for 2 full years, a little bit over. My first day on the job was out in Seattle for our USA Games. And before that, I attended one of these events the Golisano Foundation put on in Seattle. I, like you, Stan, I was unaware. I knew Special Olympics, sports organization. I knew the value of it. I didn't know about all the work in health. I didn't realize the inequities in the healthcare field for people with disabilities. Now, here's the twist. I have well, he was 14 at the time. He's 16 years with Down syndrome. It was like light bulbs went off. Everything went off. I saw why I struggle so much. I saw why everything was a little different for him, harder for him in the care. I had no idea that doctors were not trained to treat people like my son. So just want to say a big plug to NYU for doing this and keep doing this. And they support our inclusive health summits. So I just want to say from the get-go, this is an important partnership. For Special Olympics, I would love to be able to give an example of a public-private partnership that really works for us in the healthcare field. We're just not quite there yet, but we do have one in our unified sports. Unified sports is, think about your high school and think about your varsity team, your basketball team, your JV team. Now across America, we have unified teams where students with and without disabilities play on the same team. This is the law. The law requires that people with disabilities have access to extracurricular activities. So what schools have been saying when I went to school is sure they do. They can try out for any team. Now, of course, they're not going to do that. So they really don't have the access there. What the Department of Education did and the federal government did is they kind of put their money where their mouth is, where the law is. They put it in their objectives. They put money there. So Special Olympics was there and ready to partner and give some incentive money to the schools to make these unified teams. Now we match that money by almost double. They give $3 million and we end up raising $10 million on top of that to support those programs, just because in the beginning they said that was important. If we can do that with inclusive health, if we can get the government to say, doctors, you do have to be trained, we can all take it from there. Henry Schein, so that's my public side of it, but private, I could give you a litany of examples. That's what keeps us going. Henry Schein sees there's a problem, advocates it, helps us tell that story. Their employees volunteer for us. They give us equipment when we need it. They are our true partner. It's not always about money. It is about advocacy, helping to tell the story, spread the word, and if we have to go door to door to do it until the government helps us out and uses their voice to amplify it, then that's what we'll do.
That was amazing, Stacey. And the bottom line is, I think so much of this public-private partnership is about educating, because I can speak for the business side, and to the extent I believe I can speak for NYU on the academic side too. If we know, we come. I once said to Kofi Annan, the late Kofi Annan, if the UN tells industry what's needed, we'll come. So part of this public-private partnership work is really educating. And with that in mind, Dr. Mercy, give us your thoughts from where you sit on the academic bench.
Yeah, Stan, you're absolutely right. I think Henry Schein NYU relationship that's been going on for years is an excellent example of that. that partnership between a corporation and an academic institution. And I gotta say, I think setting an example is one of those traits that makes partnerships more effective. Other dental industry and health industry players see what's going on and say, hey, we want to be involved in that too. Whether it's from their sense of social responsibility, whether it's for their corporate bottom line, it is now, I think, becoming a part of the culture, and to have these public-private and academic and governmental relationships. So these partnerships often have 3-4 different partners. At NYU, we have always been in and of the city of New York. In the College of Dentistry, we visit over 200 community sites where we see adults, adolescents, children, people with disabilities, geriatric populations. That didn't happen by accident. That happened as part of our strategic plan, but it also happened because we had partners who were interested and willing and work with us. What makes those partnerships active? I think some of it's already been mentioned. Just being at the table. I can't tell you how many advisory boards we are on, both in our department in pediatric dentistry and others throughout the college. So being at the table and being able to put oral health into the discussion when there are plans being made about facility staffing, about budgets, being in the arena when some of these personal relationships are, as we know, a lot of this comes down to having that kind of a relationship. So you can feel comfortable addressing some of these issues that are sometimes not all that comfortable. Having good relationships with also the professional organizations, whether it's the American Dental Association or the American Academy of Pediatric Dentistry or organizations that work with the disability community. I think having relationships then set the stage. Whether or not we can then kind of educate our students, whether they're dental students or medical students or dental hygienists, and we can educate the public, is going to be dependent on having those strong partnerships.
Can I just add a quick comment?
Well, Steve, I'm calling upon you. I know this is the longest time you've ever kept quiet on a panel, and for which I really wonder whether the environment is such that you've changed your personality, but I'm glad to see you haven't.
Only just to add another dimension to the conversation, and I'll be very brief, which is also rare. The issue here is synergy, creating awareness, and building trust. Challenges within the oral health community specifically is the degree of fragmentation and solo actors that feel that they are the spokesperson for the issue, when in fact we're always best when we're sitting at a round table and everyone brings their unique perspective, their own skills, and collectively and collaboratively, the effort becomes more dynamic, it becomes more investable. It's not necessarily a word, but you get the point. And I believe in an old adage about the concept of AIDA, AIDA, awareness, interest, discussion, and action. And too many programs feel that they're too close, they're in the forest. So when they begin to talk to a stranger, they're immediately asking for something that the person they're talking to probably doesn't have anywhere near the background or the understanding of the issues. And therefore the ask is premature. And I think from Henry Schein's point of view, what we've attempted to do is we've always sought to understand the issue from multiple people. We've always understood where and how we can help catalyze and make a difference. And the way we are able to do it is through building the relationships and trust that you speak about, but also understanding where and how and what skill sets we bring. And those skill sets sometimes have nothing to do with the project, but we have a creative services department. We have legal and tax advice. We have the ability to talk to industry partners globally around issues. And we found that when we build a model that's working, we have the ability to scale it up, to take the example and bring it to others to replicate rather than to start over. Because there's so many common denominators in projects and in issues, but what separates it in many times is the leadership and the personalities or the geography of the program. So we tend to want to help build strong coalitions and help collectively create a strategy and an action plan that works.
Well said, Steve. The whole notion of trust, understanding is what it's all about. So my next question really relates to what has changed. When we met as a group, I remember, Steve, at the Greater New York meeting last year, we signed an agreement on a multi-stakeholder agreement on disabilities. That was in November 2019. What has changed as a result of COVID? In the world of public-private partnerships, and in particular, as it may relate to disabilities. And I guess, Stacey, your organization is really a convener of public-private partnerships. Maybe you can start and give us some insight.
Yes, what has changed? Everything has changed. It's like it was a landslide in March. We are an organization that we see our athletes on the field, we see them in the pools, we see them in the courts, and we see that's how we see our coaches. And in March, that just all had to come to an abrupt end. Now, we could have just said, all right, well, you know, when we're allowed to go back outside again, we'll give you a call. We just knew we couldn't do that because what we knew then, but what we know so much more now is how isolated our athletes can be. Special Olympics is sometimes all they have, and it was taken away from them. So we had to move very fast. And I think during that time, everybody wants to help. Where's your urgent need? For, you know, our funding changes. We do fundraisers all the time. You can't do fundraisers. No one wants to go to galas anymore, right? No. Anyone want to go to a gala? No, probably not. So, so we had to change our whole business model and everything. And I think that is where the partnerships really come in, by having partners. And I think Henry Schein, we had all this PPE when everyone was needing it in New York City, and we had it in storage. We call our partners and say, is it okay if we, you know, give it to our group homes and we give it to where it's needed? Of course they can. It was our partners that were established, the Golisano Foundation. It was just so refreshing to have them call and say, just tell us what you need to get through. Not what are you going to do or where is it right now, but they supported us as an organization. They knew they just had to help us pay for the boring stuff, to be able to keep the lights on, the operating thing, to be able to keep doing what we're doing when this pandemic has passed. We had to get up quickly on the screens, which we did, and our training clubs and everything. But, you know, it was an abrupt change for our organizations, and it was our longstanding partners that helped us get through, and will continue to make sure that we are there in 2021 when we all can emerge from our masks, hopefully. It's partnerships for us is absolutely everything, especially right now.
Well said, Stacey. The only thing I would take a little bit of umbrage with is I can't wait to go to fundraisers again.
Well, I am going to get your address.
I will be so appreciative. I've been starved of seeing anyone.
Well, you can polar plunge. We're still having people jump in cold water, so if you want to do that.
No, that's
we'll
delegated. I have to say, that is delegated to Steve Kiss. Who wants to take a shot at framing how you see the change in relationships amongst the various players as a result of COVID-19?
I'll give an example. So one of the key lessons from the pandemic in my mind was and continues to be the need for preparedness. Unfortunately, the erroneous belief that we are prepared. And in 1912, we received another wake-up call, except it wasn't from a virus, but from another facet of nature, ice. It was the sinking of the Titanic, and it's another example of us thinking that we were prepared, and they weren't, and we weren't again in 2019. It was and still is an example of hubris, excessive pride, coupled with blinders, and that's a lethal combination. The biggest change that we had relates to Anastasia's experience. As an example of COVID-related partnership opportunities, was the almost immediate and universal issuance of a rule from all hospitals, as she said, prohibiting visitors to be with hospitalized patients. While this prohibition was based on sound epidemiological practices, it placed patients with intellectual and developmental disabilities in peril. Their survival requires support and assistance. They have low resilience, they're vulnerable, and basically they're nonverbal. My agency, the Orange Grove Center in Chattanooga, a community provider of supports for people with IDDD, formed a partnership with all the area hospitals to allow our individuals to be accompanied by our knowledgeable and skilled staff, what we call our direct support professionals. They were able to serve as patient advocates and providers of key information that contributed to very favorable outcomes. It was a win-win partnership for everyone. It's an example of the integration of needs, knowledge, and experience. And a footnote to this partnership was that shortly after, the Office of Civil Rights of the U.S. Department of Health and Human Services required all hospitals in the U.S. to allow designated staff to be with hospitalized patients with disabilities. But I see that we basically have served as community incubators in New York and also in Chattanooga to basically presage the decision of the U.S. Department of Health and Human Services. So it's an example of locals getting it.
Dr. Mossy.
Yeah, I would say we've seen some similar things. Certainly, when COVID came on the scene in March, the amount of resources, certainly the amount of the funds were depleted across the board, whether you're at a dental school or whether you're a community health center. But I think the silver lining that's come out of it, we've talked to a number of our community partners, and they have said, hey, look, you know what, we'd love to have you in, but because of either city or state regulation, we're allowed to, or we've just had to close our doors, period. So that makes it much tougher to serve those populations, and many of those community sites that we visit are schools, centers for adults and children with disabilities. But it opened the door to a lot more dialogue than we've had in the past. So that was, I think, a plus. It allowed, I think, corporate entities. We've seen some corporations come to us, for instance, and say, hey, look, can we help? And these were maybe not conversations that we'd had before. For instance, Colgate, who has vans that goes throughout the community here in New York City and do great work, do a lot of screenings in schools and community centers, he approached us in large part because of COVID. Our work with Bellevue Hospital, for instance, where we have a pediatric dental clinic and we have a strong presence, actually increased because there was a need for more integration of medical care and dental care, and certainly telehealth. Telehealth has just exploded because of it, and has led to some unique partnerships. Again, companies who work in telehealth now approach us and say, hey, how can we help? So because of the restrictions and the lack of resources, I think that has, out of necessity, increased opportunity for some of these partnerships, which will undoubtedly be maintained and continue post-pandemic.
And by the way, I agree fully with you, Dr. Mossy. Steve, many years ago, you pioneered in the dental industry the notion that it wasn't good enough to write a check out for a charity, but to get engaged in the charity. You, of course, worked on Give Kids a Smile, and you've done a number of these activities where business collaborates with academia, with the profession, with other NGOs to actually hand in hand make a difference. What we do know is COVID has resulted, and it's actually started about a year or two before, when the Business Roundtable came out with a statement saying what is important is stakeholder capitalism. Now, companies, the business of companies can't any longer be simply the business of making profits, but you have to be involved in the stakeholder, a dialogue, and all have to work together. Your thoughts, has COVID now made companies understand that yes, it's important to write the check out, but the kind of work that you've been doing, for example, with Give Kids a Smile and the disabilities world of actually getting teams involved in the issues, do you think that's moved along?
I think it's actually reinforced the concept, Stan. I think that the organizations who saw themselves as quote unquote sponsors to attend an event suddenly realized that there were things that they could do beyond just writing the check. The most importantly is we all have different core competencies, both in industry as well as in the healthcare, education, and community services space. What we found early on was that we had the ability to help organize and facilitate and provide logistics and infrastructure to support events in multiple locations. There aren't that many organizations who can do that. And we also had the ability to talk to the clinical community, the academic community, and industry, all with a message that really needed to go to the public and then subsequently to policyholders. I think for COVID, where we found ourselves again in a unique opportunity is that we had relationships because of our medical business with government agencies. The medical community was in need of PPE. We were part of the Skybridge program with the White House. But at the same time, we realized early on that advocacy for the dental profession, that although many states required them to close as an elective procedure, all of them were expected to provide emergency service to patients, and in many cases to stay open and take on the patient flow. And through your leadership, Stan, and also some of the folks in our procurement and logistics teams, we established a relationship with FEMA and some of the government agencies on behalf of the profession of dentistry to point out the critical work that oral health does for the community at large, and clearly the underrepresented populations, the disabled populations suffered along with everyone else. But at the end of the day, we took on a role to help dentistry reestablish its importance as a community primary care provider. We're advocating, we're acting in as many ways as we can to put dentistry's important best foot forward so that we're not sidelined in the future when, in fact, the public wants to visit their dentist, can't wait, and creates appointments for care. And we found ourselves trying to make a case of PPE support for the profession. And so from my perspective, industry can play a tremendous role in almost every type of project for the good of the public.
I'm going to call upon you again. And why? Because I would like you to set the tone so that our three other panelists can really jump in. Back in July, you facilitated putting together a LinkedIn article co-authored with Neil Romano of the National Council of Disabilities. The article examined the importance of oral care and primary care for people with disabilities. And of course, the lack of equipment in this area to treat patients with disabilities. And a big issue, and it's been covered today, the lack of cultural competency of practitioners. And it's not, by the way, only dental, it's medical as well. And in fact, in some ways, a bias against handling, treating patients with disability. So how do we, and I'd like, Steve, it was your idea to put this, the two of us together to write this article. And perhaps just set the tone for our three other panelists to answer. How do we deal with this issue of lack of understanding, lack of equipment, lack of focus on dealing with what I think is over 10% of the population who have needs that are just not satisfied by the healthcare community. Steve.
Oh, okay. I thought you wanted their input. So we agreed with Neil Romano, who spoke earlier today on today's program, and appreciated his calling out the relationship that we signed, which was a memorandum of understanding. And we were going to take on 3 issues. Because we represent about 3,500 manufacturers in both medical and dental product, we were going to work with them to highlight the products that they already have that have special applicability and adaptability to serve this population. And we also were going to help develop and bring the attention to these companies that if they aren't already working on something from their perspective that could be serving this market, that they should. One of the earliest outcomes of this discussion, and also a fellow member of organizing Project Accessible Oral Health, Colgate, provided an innovation grant to the University of Pennsylvania Disability Center to create new innovative clinical treatment and clinical device techniques. We also took on, through our design service, the availability and the guidance of the Americans with Disability Act guidelines on the physical layout and the space for practices, both medical and dental, and how do you comply so that your practice is physically able to literally be used by a patient in a wheelchair and other things like that. So these 2 pieces are evolving. We started with editorial and with outreach through our marketing teams to the manufacturers. Our advocacy to the dental community is building. It just started actually this fall. And going forward, you'll expect to see a tremendous amount of visible advocacy to dentistry and to dental industry on the importance of putting a new focus and a new priority on serving the disabled as patients, and quite frankly, both from a social justice point of view as well as a health equity point of view. So we're expanding the voice of the issue and using our media and our marketing and our relationships directly to help influence them to come around with innovative ideas, innovative products, resources, samples, supplies, and also in certain appropriate cases, funding. So we're bought in to the issue of the importance of oral health for individuals with disability, not only for their well-being, but for their social and other quality of life issues.
Stacey, blank piece of paper. How can we in industry help draw attention to the importance of the work you're doing? Because I believe that if the public and industry knew more about the work you're doing, there would be much more support. What can we do? What is missing? What's the communication link?
I totally agree with you. I don't need a blank piece of paper though, because I would just point them to the dentists, what they have done, the industry, the professionals. They saw really a social justice. They saw the inequities in treating people. They knew it went back to in educating the dental students to learn more about people with intellectual disabilities and how to treat them. Once you do that, you're fixing the problem in generations. It's going to make a difference. The dentists weren't sued to do this. They weren't told by they decided to do it themselves, and that's what the rest of the medical community has to do. Listening to Neil Romano talk today, I mean, every time I hear him talk, I feel like quitting my job and just protest, being a one-person protest about the inequities, what he is talking about. You want the government to step in and say, you need to train residents. All residents need to be trained in treating people to treat my son. You're talking about my son. This isn't some, odd population. These are our children and these are our athletes. But if Neil Romano has to write a memo to states saying, don't forget about people with disabilities, and some of the states, I want it not to be New York, but I can't say that it wasn't, says they're the last on the list. we're not going to get the answer from the government. They don't get it, or they simply don't care. But I truly believe in my heart that people who want to be doctors and providers, they are not going into this profession to not treat all people equally. So they want to do it, but it has to start with the medical schools to say enough is enough, and we want to make sure that people with disabilities have access to fair medical, equitable medical treatment. It's all really just about communication. My son, the really biggest part is he can't say what hurts, when, and where, and exactly how. So it's kind of like a little bit of a mystery. But I think his doctor is a lovely person, but she gets nervous and she'll just send us down to the ER, and she just doesn't really know the answer. So we need to just start with getting her to know the answers.
You know, Stan, let me just reiterate that the whole concept of the healthcare disparities for people with ID was actually first identified by former Surgeon General David Satch in 2002 with the release of his landmark report. And one of the crucial finds was the lack of training that we've been discussing all day of clinicians in the competent collaborative care of patients with complex disabilities. You know, the findings were, the reality was there were no lectures in medical school, there were no patients, there were no texts, there's no clinics, there were no mentors, no journals, and then probably the most important thing, there were no questions on the national boards, which obviously influenced the content of curriculum. And there were no expectations. And one of the responses was the creation of the American Academy of Developmental Medicine and Dentistry, which is the country's only true bicameral organization that basically enlists physicians and dentists together. And of course, one of the goals was to influence clinical training starting in medical and dental schools to ensure that graduates had the confidence, skills, and tools to do that. Originally, CODA testified that they should basically encourage dental students. Well, the difference between should and must is seeing a 45-minute video versus rolling up your sleeves and going into the clinic and actually working with them. And it was working with Neil Romano and the NCD that led to the mandate that all dental students must receive competency-based training, which was really elevated the entire profession. And now we are using that same model of influence in connection with accepted ethical standards. And our next goal is to ensure that all 192 US medical schools, and that includes both the allopathic and the osteopathic medical schools, to make sure that same commitment to ensure training is provided to medical schools. We're beating a dead horse, but one aspect of bridging this gap is to mentor and groom the next generation of clinicians like they're doing here at NYU. Unfortunately, you can become a board-certified internist or a board-certified family practice doc without ever having the experience of examining an individual or speaking to an individual with Down syndrome, Fragile X, autism, or a variety of rare and unusual diseases. One of the ways that I encourage dental students and medical students to work at my clinic is to go beyond the warm, fuzzy feelings that you're doing the right thing. And that's basically to encourage their grooming as good clinicians. If they can basically get a pain history from a nonverbal person, then they can get it anywhere. And so basically it is a proving ground to increase your clinical acumen, which should be enough for any physician.
I would say the training.
Dr. Mercy, I want to put you in a very awkward position because I'm going to call you Professor Mercy for a minute. Professor Mercy, NYU pioneered the notion of global outreach for its students and made students that go to NYU aware of another part of society, poor people that don't have access to oral care. What can you suggest that NYU and other dental schools do to make students aware of 10% of the population that are underserved?
If you build it, they will come. I think the courage to create this oral health center for people with disabilities and enough to be part of the group that helped plan it with leadership from the university. This has become now a nucleating center. So within just months of making the announcement, we heard from dental schools around the country and around the world. I personally got a number of people calling up, hey, what do you guys, and one, they were inspired and they wanted to see how we were going to do it. I think two, there was maybe a little sense of competition. Well, wait a minute, if NYU's doing it, maybe we need to, they've raised the bar. But also, I think to Stacy's point, I think people genuinely want this to happen. It's the wherewithal, right? Our budgets are already tight. We possibly do that. We're shorthanded on staff. There's always reasons why you can't do this. But I think once someone, then it sets a bar, it sets the example, and we've had dozens of visitors, Ron Kaczynski, who led the earlier panel, countless tours of visitors from around the world of wanting to see if they could emulate this back home, not to the same scale, but certainly trying to increase access to this population. I think that's one thing. Also on the travel, we were contacted immediately by people who wanted to volunteer for additional training. So these were dentists already out in the community who didn't get this training during their dental school or their residency and wanted to come in and get additional training for us. And we're asking, hey, do you have CE, do you have hands-on, do you have a fellowship? So in fact, now we're trying, so Dr. Courtney Chin, one of the faculty in my department, recently was awarded a $2 million grant from HRSA to do just that. And one of the parts of this training grant is to create a fellowship in oral health for people with disabilities that will work in our center, but also out in our community sites once we can go there, because we work with a lot of schools and community sites that service the children and adults with disabilities. So I think one of the reasons HRSA awarded that grant is because they saw what NYU did, what with the facilities we had. But also at the corporate level, we've been approached by companies that say, hey, look, you know what? This alerted us to this. And so we are now developing a new toothbrush, for instance, that could be used for people with disabilities. Can we come talk to you? Can we come market this with you? Yeah, these are the sorts of, I think, maybe unexpected consequences that you get from taking that leap of faith. And I think we're going to see more and more of that come down the road.
Thank you very much. My notes now tell me that at 1:30, Executive Vice Dean Mike O'Connor will facilitate some discussions with the public, with whoever's on this call and may want to ask a question. I don't see you, Mike, on the line.
Here I am. I'm here, Stan. And thank you for that. We do have some questions from the audience. Is there anything that anyone on the panel would like to say first before I go to the question? One I'd like to read to the group, and I think this is open to everybody. This is from a dear colleague of ours who's also been very instrumental at the Oral Health Center for People with Disabilities as an advisor, and he's on our advisory board as well, the Oral Health Center for People with Disabilities Board. Dr. Ralph Epstein from SUNY Stony Brook notes that as of a few years ago, 28 states and Puerto Rico mandated that children below a specific age and patients who are medically compromised, as stated by their physician, were to be covered for general anesthesia and hospitalization for dental care under their medical insurance policy. New York State is not part of this group, even though New York State Dental Association year after year has attempted to get New York State legislature to require this action. His understanding is that this legislation proposal never got out of insurance committee. Dr. Epstein asked the question, what could be done by this group of experts today to see that this legislation gets passed and approved?
Michael, I'll jump in real quick. as a pediatric dentist, what I do, and this is what my team does, we have at times over a 6-month waiting list of 3- and 4-year-olds waiting to have dental treatment under general anesthesia in the operating room. Many of them are children with disabilities. It is of the, I think, hallmarks of the poor oral health system and payer system and reimbursement system that we have, that happens. I have visitors from around the world that come many from developing countries, and they can't believe that this is happening in Manhattan, in one of the richest cities in the world. So there needs to be legislation. I think there needs to be advocacy. In this sort of group, and certainly the center here at NYU can advocate for that. But I think the most successful way is probably put it at that individual level. If you talk to any of these parents, any of these mothers or fathers that talk about their children, I think you'd be hard pressed not find a way to create and create funding, especially when you look at it in the context of the whole healthcare pie. It is a drop in the bucket as far as financially speaking, but it also speaks to how can we avoid this to begin with. And I think that's one of the things we're doing here at NYU. Every graduate will be able to at least assess any child, whether they have ability or not, so that we can identify these issues very early, by the time they're 1-2 years old, as opposed to by 3 or 4, they're already on the waiting list for the OR. That's too late. So that's certainly one of our goals at NYU and with the center. So I think those are a couple of ways where collectively we can make a difference.
Terrific. Excellent. We're right on time, and I want to thank Stan and Rick and Stacy and Steve, and of course Amir, for a terrific panel discussion. Thank you all very much. I want to invite Stan Bergman to say a few additional words, if he would. Stan?
Thank you, Mike. I'll be very short. Public-private partnerships, in my view, is really the best way to address issues in society. At the beginning of COVID, there were real issues in the supply chain. We unfortunately have not thought through the challenges of PPE being concentrated in certain parts of the world, and we had to deal with it. A public-private partnership was convened, and I believe a lot of good work was done. Unfortunately, it took a while for that public-private partnership to kicked in, and today we generally have enough PPE. If anyone has any issues with PPE, of course, Henry Schein be happy to help. So to me, I'm a big advocate for public-private partnerships. NYU is in a great position to convene. Mike, you, Charles, convene us. This private sector will come and no doubt will bring the NGO community with us. They've always supported NYU activities. So thank you for standing today, and a very, very important topic that each one of us has to advance from a societal point of view.
Thank you very much, Stan, and thank you for spending as much time as you have with us, and for all of the wonderful things that you and Henry Schein do for the NYU College of Dentistry. So thank you very much. Well, I want to also thank all of the moderators and all of the panelists for a great, from my perspective, a terrific program. In my view, today's symposium focused on funding, access to care, equity, advocacy, awareness, and education, leveraging, as Stan just said, the partnerships between private, public, academic, and government agencies and organizations, with the goal of improving access to care for the underserved population of people with disabilities. Obviously, as many members of the panels have already suggested, there is much still to be done, obviously. I hope that we continue today's dialogue by actions in our everyday lives. So with that, it's my pleasure now to introduce our Dean, Charles Bertolami, whose vision and experience from that time he walked across the street on 25th Street many years ago to where we are, not only in the Oral Health Center for People with Disabilities as our clinical care and training programs are housed, but also leading to today's discussion as well. Without that, we wouldn't be where we are today. So thank you, Charles, for everything you've done for this particular population.
Thank you so much, Michael. You know, I've been sitting here listening to the presentations and the dialogue, and I have to admit, I have a kind of a mix of feelings coming from the discussions. On the one hand, I found presentations energizing and inspirational. My admiration for so many of the people that spoke who I know and was already great got even greater. On the other hand, what became crystal clear is how daunting the task is. And people respond to daunting tasks in different ways. They can be demoralized in a sense. And I think it's important not to let that happen. And Steve Kess used a word, it came up a couple of times, but the most recent time was he used the word awareness. And I think that's part of the answer, actually, because we each have different gifts based on our inclinations, our training, whatever the case may be. And so for the clinician practitioners on the one hand that are treating individual patients, generally one at a time, I think the question is, you know, what can I do as an individual practitioner? Amr, I thought that was very inspirational when he indicated that dentists have already contacted him who have wanted to do volunteer experiences in the center because they recognized a need and they decided to be people who noticed. And I think that is central to the awareness question. For educators, I think we have a particular privilege here at this particular dental school. We graduate about 380 students a year. And so there's this unique privilege in a way of amplifying the influence of professors. And what we're trying to do is to amplify that influence in the area of competence and compassion in the area of people with disabilities. For those who have the gift of public advocacy, I think one of the messages that came through to me today is how grateful we need to be for people who have that particular gift. And they may be physicians, or they may be educators or dentists, they may be practitioners, they may not be. But they see the big picture in a way that I think is critically important. And Assembly Member Joanne Simon pointed to the fact that it is very important for policymakers to understand that at the end of the line, there are real people being affected. And the advocates are the people who can communicate that. And then there's the disabilities population themselves and their families. They're very extraordinary and moving advocates. I particularly like Anastasia's comment, not to plan out us without us. I think that's extremely powerful and important to keep in mind. And then lastly, there's the corporate sector. You know, the corporate sector, I think, is probably the most tuned in and the most sensitive to what's really going on in society at any one moment, because it's part of their business to do so. And I don't know that we've always taken advantage of that recognition and to use that partnership in a way that helps us move in directions that the corporate sector recognizes before any of the rest of us, particularly those of us in academics, would recognize. They are experts in communications and marketing, and those are all skills that we need. The word communication came up many times. So what I got from this was a blend of gifts of some very extraordinary people, both who spoke as speakers and as panelists, but I have no doubt that among the people that were interested enough to become participants in this through their attendance have that mix of gifts and skills as well. So there's much to learn. It can't happen if the question of populations with disabilities are beneath the consciousness, either the practitioner or the profession. And that's what we have to change. So I want to just conclude by thanking all of the speakers and the panelists. I want to thank everybody that attended. As I say, I hope that this is the first of similar meetings to take place in the future. And I hope that even though we couldn't meet in person, a lot of the networking that goes on at an in-person meeting, at least virtually, we can make connections with each other that may not have been possible before. And then lastly, I especially want to thank the folks that actually pulled this off amazingly smoothly, in my opinion. I'm talking about the people behind the scenes. And I just want to list them very quickly because they've been so extraordinary in making this all happen. And they are Elise Bloom, Robert Arasate, Connor Lillis, Stacy Ripke, Ryan St. Germain, Molly Washburn, Ken Fauerbach, Elise Eisenberg, and Jean Giordano. You know, one of the good things about a large school is that you've got a division of labor and people that are really good at what they do. So thanks to all of them, and thanks to all of you. And with that, I'll